Got it. Now I also join with my ID. You allow me. Let us see. Sir, ನಿಮಗೆ YouTube ಲಿಂಕ್ ಕಳಿಸಿದ್ನಲ್ಲ, ನೀವು ಒಂದ್ಸಲ ಚೆಕ್ ಮಾಡ್ತೀರಾ?
YouTube.
So now I also join with my ID. You allow me. Sir, ನಿಮಗೆ YouTube ಲಿಂಕ್ ಕಳಿಸಿದ್ನಲ್ಲ, ನೀವು ಒಂದ್ಸಲ ಚೆಕ್ ಮಾಡ್ತೀರಾ?
Work and convincingly in trying to reduce mortality, reduce the symptoms. And today we have a winner in the form of both these drugs, dapagliflozin and empagliflozin, in trying to treat HFpEF. We have a class 2B recommendation for MRA and a class 2B recommendation for angiotensin receptor blockers and ARNI also. So that's summary for treatment of HFpEF. And thank you.
Thank you, sir, for that wonderful presentation. I would now request Dr. Keshav also to come up on the dais. The forum is now open for discussion.
Ejection fraction is that
Exactly, sir. It's a class 2B, sir.
class 2B, not as good as
the Paragon HF clearly said that it works, but you know, it fell short of it was about 11%.
yeah, okay.
11%, which really fell short of the required. But in patients, especially they are found in ladies, in female, it works. And it's also, if you start hair splitting there in the sub studies, we have clearly shown that people who have ejection fraction less than 57%. When you're going towards 60, probably it doesn't work. but that 40 to 57 range, it seems to be working there.
Okay.
So, but the problem was, all these patients were put into the entire thing, and they said probably it doesn't work. That 11% was not adequate. But then they found that in this subset of patients, females and in patients who have borderline LV function, mid-range to the upper limit of mid-range, probably there it does work.
Okay.
So I think we need to wait and watch. That's why right now it has only a class 2B recommendation. We need to probably use it judiciously.
Yeah. Thank you.
I think this is a very clinical question to Dr. Keshav. How often do you repeat pro-BNP? And are there any guidelines for a clinician, physician, diabetologist treating? Because patient wants to know, is my heart failure under control? 15 days back we had done, when do I do the next test?
No need. The guidelines doesn't recommend a serial measurement of NT-proBNP. Only if you have a dilemma of worsening scenario, we do. Suppose a patient comes with breathless, NT-proBNP is 10,000, you're stabilized. Should I monitor him repeatedly and then adjust the medicine? There's no guidelines. The serial measurement of NT-proBNP in guiding the treatment has been a failure study. So it's not proved that I should measure it day 2, day 3, day 4, so that improvement. Suppose it's not improving, I'll increase the diuretics. Has not been proven this. But first admission you do. Afterwards, maybe if you have a repeat admission, readmission or worsening scenario, or sometimes you are bothered that patient has an infection, you don't know whether it's a worsening heart failure or it's an infection, then okay, you do that compared to the old value, how much. But the first value itself will tell you the prognosis. 10,000, very bad patient. 1,500, 2,000, okay, reasonable. So diagnosis, prognosis, severity, all the three are this one, but serial, no guidelines.
Okay. Are there any specific methodology by which this NT-proBNP done? Because we hear that point of care devices are likely to hit the market, especially with so much of emphasis on pro-BNP.
It's just
are there
like
any specific methodology which says, okay, this is good, like for HbA1c, we know what is the best method. Do you have any such methods for NT-proBNP or any lab would do?
NT-proBNP point of care is there already,
Yeah,
but not much experience. We're not using it. So there is I think Narayana uses heart failure panel. As soon as he comes, troponin, myoglobin, CKMB, NT-proBNP, a single drop or a single 5 ml blood, everything can come. So it will tell immediately if the patient is heart failure, MI, everything will come to know in that picture, but not very
Quantitative evaluation would be better. At least it gives you the numbers. This will tell you, yes, it's positive or negative. But if you can quantify it would be better. And also age related. It's also age related. Elderly people, even up to 1,800, NT-proBNP is still okay. You're not really worried. In somebody who's 60, an octogenarian or a septuagenarian. So probably point of care would suggest that he has heart failure. But if you want to really assess his severity, I think quantitative evaluation.
It brings us to the question that troponin mildly positive.
okay.
So that question and make the patient, doctor, everybody hyper anxious, and patient is immediately referred off to mildly positive troponin. So the BNP quantitative will become like qualitative will become like quantitative.
And so many panels which tells you everything. When do people use a stethoscope now as cardiologists? Okay, I think there is another question.
Yeah, I have a question, Dr. Prakash. I think you were mentioning that there was a classification where people have HFrEF and then the ejection fraction improves, so it recovers. So questions patients often ask us is, at what point can my RNA be down titrated? After how many months or years can you do this? Because it's expensive. So do we have any evidence on this?
There's a large review article on this now. Once they have improved ejection fraction, they have been in the HFrEF range and they've improved, you still continue to treat them as if they are in the HFrEF range. Because these drugs are what brought them to this level. So you can't withdraw that support. They should thank themselves that they have reached normalized LV function thanks to these pillars. So I don't think at any point you can withdraw these drugs.
So let's say there is someone whose blood pressure starts falling at that point when you reach the highest dose of ARNI. Do you at that point want to down titrate the ARNI or
Perfect,
keep it
perfect.
there and down titrate one of the other medications?
I think they've again shown in another recent trial, even lower dose of ARNI works. So if at all you can't reach the 200 milligram twice a day, even 50 milligram twice a day is good enough. It does bring about the required changes. You may not get the results like 200 what the randomized trial showed, but even 50 milligram twice a day in recent study, they've said works quite well.
But
If
do we have,
hypertension is an issue, definitely you have to bring it.
but is there any evidence to say, okay, a low dose ARNI plus a higher dose of beta blocker versus the highest dose of ARNI, and you keep the lowest dose of beta blocker or let's say one of
I
the
think
other drugs. So which would be
blockers-
better from a
Beta blockers
cardiology
you
point?
go by the heart rate,
Okay.
one of the issues, and then some kind of optimal dosing. ARNI 50 milligram twice a day, 100 milligram twice a day, but at least in the paradigm HF has said 200 milligram twice a day. So that's the kind of dose that we need to reach, which we, I think, can never
Very
ever.
rare.
We probably are still around 100 twice a day, or that's the maximum we are reaching. Beta blockers, I think you should go by the heart rate rather than, that would be the way to assess adequacy of beta blockade. SGLT2 is not really going to compromise much on the blood pressure. Diuretics is something that you can do away with. So I think that way you can titrate a patient and still continue to persist with ARNI in a reasonable dose.
Thank you.
The other, what Dr. Prakash told is, if the patient BP is low, reduce the diuretics rather than ARNI, because diuretic doesn't reduce the mortality. ARNI reduces the mortality. So other question is, you wanted to change ARNI to AC inhibitor. In the paradigm HF trial, those who are on AC inhibitor, when they were went to ARNI, P value is 0.00001. So it is like a mortality reduction is superior, much more superior to AC inhibitor. So that's where we have to convince the patient that you are definitely going to survive better with ARNI than with the AC inhibitor. Yeah, by down regulating to AC inhibitor, you will save financially, but the mortality reduction is 0.401. You don't see in any trial with so much P value. So I think you have to convince the patient that ARNI is better to survive.
Thank you.
I have
Is it that it's the valsartan which is doing the trick, or is it?
sacubitril.
No, sir, it's a
Sacubitril
combination. It's a combination.
Because both the
Because
both,
very clearly,
Correct.
valsartan is inhibiting the RAS system. But the problem is a rebound effect, and this works on the NP, BNP, and then this combination is what is really making the difference.
Has anybody done a trial with telmisartan and sacubitril to see whether it gives a
Yeah,
similar
I
effect?
do agree with you. It's possible, but because I think both the molecules were there.
from-
Yeah, there was a-
Novartis, so they used valsartan by default,
Yeah.
but it should work with any other ART, absolutely.
sir,
But you
one-
can't combine an ACE with a
Yes, you can.
neprilysin inhibitor, because both of them, the bradykine becomes much more, and a lot of them develop angioedema and that kind of complication. So that's a very fatal combination. ARB and neprilysin inhibitor is accepted.
Sir, I'm trying to compare oranges and apples, but I have a stupid question. Hope you don't mind it. Now, for screening for heart failure, asymptomatic screening for diabetic patient for heart failure. Now, echo versus BNP, what would be
So
the future?
I would use
Both.
spectral tracking. I would look for global longitudinal strain
Okay.
and even circumferential strain on the LV. That is the most subtle way of
Of-
assessing somebody's LV function.
Okay.
And it's been proved, especially in those with HEF. HEF, yes, they'll be,
Will
the
give-
longitudinal
you
strain
can-
will be reduced. But in HEF, both of them will be reduced in comparison to ejection fraction. Ejection fraction will be normal. But
Okay.
if you start looking at the circumferential strain or the longitudinal strain, it will be low. And NT-probe will be necessary. Yes, there's a easy yardstick, bedside that you can
Yeah, that
estimate.
the question
Yes,
was
but
to
that
say,
is, when they're already gone into heart failure.
for screening,
I think,
echo.
the echo the spectral tract.
Thank you. I think we're going to get more parameters in the future to predict heart failure. That's what it looks like. Thank you.
Sir, excuse me, sir. Regarding the up titration of ARNI also, what is the time gap? You know, when we start with a smaller dose.
As far as possible, as rapid as possible. And for fast, rapid sequence, try and put in all the four and rapidly, up titrate.
Okay. So how early they can tolerate the dose?
You are looking at blood pressure, so on and so forth.
And when it comes to echo, like when we have seen the changes, when are we going to see the improvement in the ejection fraction on the like time?
First of all, working on the diastolic
Okay.
component. So patients start feeling better. We have
Yeah,
seen this with
symptom.
our recent therapy. We put a CRB. Healthy function remained 30%. From 5, 30, 6 months, but we start seeing he's much better. He's able to walk from class 4, we come to class 1. But healthy function remains 25, 30%. So this is so diastole is what starts working on system. Maybe difficult for echocardiography. Logical strain again probably would be more subtle.
Sir, what about COVID? Post-COVID, is there a chance of more thing of heart failure? Is it one of the sequelae to COVID? Are we?
Long COVID. Long COVID is a big issue going on. We do see some patients. We've been following them at our hospital. Some of them we typically see who have gone into this kind of long COVID issues.
Okay.
Myocarditis, subtle myocarditis.
Oh. So where the structural damage. Thank you, sir. Thank you for that wonderful session.
The last question, sir. Sorry for that. Generally, what happens for the diabetics, we always know that diabetics always get into the heart failures and we always tend to miss it out in the early stages. As a clinician, what are the first or 1 or 2 signs what we have to really look in before we subject him? For example, a diabetic patient walking to us, you say them to go for an echo or something like that. They always resist. They say that I came for a diabetic checkup. You're telling me to go for a heart checkup. Is there any signs for us to pick it up early so that we can just tell the patient, yes, this is very important. You have to do it.
Sir, your question, Dr. Keshav will answer, but I have one point to make, sir. At this point, out of context, all diabetics, put them on statins. Please, from day 1, start them on statins. Don't allow them to go into stage 4, stage 5 atherosclerosis, and we see them, we have to do rotablation, we have to do all kinds of.
And it is a moderate to high dose statin.
Very, very important, sir. That's an appeal. Thank you.
It is moderate to high dose statin, not 10 mg, 5 mg. Minimum is 20 mg atorvastatin. Go to 20 to 40 is better for all diabetics. So if your diabetic patient is not physically active, you don't need to do a echo or anything. If he says I'm walking 3 to 4 kilometers every day within 30 to 40 minutes, even in 1 to 2 years, 2 years once you can do an echo or something. Plain simple ECG, any abnormal ECG will give you a clue. And anybody who is 5 years, 10 years of diabetes, maybe you're justified in doing a treadmill test because all of them by that time will develop significant atherosclerosis. Any patient with a gangrene or a peripheral vascular disease is already coronary patient. Anybody with a cerebrovascular disease is already coronary patient. So you have to start with 40 mg atorvastatin blindly and try to see LDL after 3 months, whether it is come down to less than 75, if it is less than above 100, again up titrate the statin. Physically active, if person is physically active, we can check it. This one, but you have to ascertain your physical activity of the patient.
Okay, thank you, sir. Thanks for that wonderful session.
Question,
Now we
sir.
close the session.
Sir, one more question.
I think you can take the questions personally. We are running short of time for the next session. That's a virtual one.
Sir, role of SGLT2 inhibitors in non-diabetic population. How do we manage the hypoglycemia?
Hardly any hypoglycemia. If you see compared to controls, hypoglycemic incidences are very, very few and minimal. So you don't have to worry now. SGLT2 inhibitors have now moved into the cardiologist realm. Don't worry.
So what
You
is the
don't have
dose?
to worry about.
What is the dose that we use, sir?
Nothing will happen, sir. No hypoglycemia, nothing.
Dose.
Dose, the full dose. 10 milligram of DAPA or 25 milligram of EMPA.
Thank you, sir.
Thank you, ma'am, and the speakers for an insightful session. I would now like to welcome my mentors, Dr. S.R. Arvind, Director and Chief Diabetologist at Diacon Hospital, and Dr. Bhavna Sosale, Director and Consultant Diabetologist at Diacon Hospital, and Dr. Sanjay Reddy, sir, Consultant Diabetologist and Director CDEC, and Consultant Diabetologist at Fortis Hospital. Over to you, sir.
Thank you, Saima, and one small announcement before we start off the international speaker forum. There was a delay in starting the tea and the high tea break. The snacks and coffee tea is available. So in between, we have next 2 to 2.5 hours of stretch. So if anybody wants to relax for a few minutes, use the toilets, of course, you can always go there. Can I have the Zoom link, please? The live Zoom link on. Can I have the live Zoom link on? Because now we are connecting and going directly to Boston, where I was told is about 2 to 3 degrees, and Dr. Rohit Kulkarni is waiting. So I would like to introduce him when once we have Dr. Rohit live on the Zoom. Okay, I can see Dr. Rohit live. Dr. Rohit, can you hear us?
Yeah, we can hear you, but very, very faintly. Good to see you, Arvind.
Thank you. I think we'll try to work on the volume as we go on. We can hear you very clearly. I hope the volume has been increased at your end. You can just check that once, but we can hear you very clearly. And this is a microphone to ask questions. So we'll try to figure out, and do tell us if the quality of the volume is okay at this point of time from our side.
Yeah, I can hear you now a little bit better than before. But in the previous session, I could not hear any questions. So
yes,
this microphone is good.
We had not connected the microphones to the Zoom outlet, but we can hear you very clearly. Thank you, Dr. Rohit. I know it's 6 o'clock early in the morning at Boston, and so very grateful that you are up on a Saturday morning, missing your run. I was told it's 2 degrees in Boston with flurry, snow, etc., etc. Thank you very much for being there for us. So Dr. Kulkarni is the HMS Professor of Medicine and co-head of the section on islet cell and regenerative biology. He is the director of the P&F program at Jocelyn's Diabetes Center and holds the inaugural Margaret A. Congleton Endowed Chair. He is the principal faculty at the Harvard Stem Cell Institute and associate member of the Broad Institute. Dr. Rohit Kulkarni is a recipient of the Endocrine Society's Ernst Oppenheimer Award and Albert Reynolds Prize and the Julio Santiago Memorial Lecture. His lab is invested in understanding mechanisms that underlie pancreatic islet cell regeneration and hepatic metabolism, with a focus on growth factor signaling, induced pluripotent stem cells, and mRNA methylation. Dr. Rohit Kulkarni graduated from Bangalore Medical College and then went on to do his MD from St. John's Medical College, actually in Bangalore. So we are very proud that somebody from Bangalore has made such a big name in the field of diabetes today. It's over to you, Dr. Rohit. You can take on from now.
Thanks, Arvind, for the introduction, and it's a pleasure to be here. Let me start by sharing the screen to be sure that you all can see this.
Yeah, we can see the slides. We can hear you. You can start, Dr. Rohit.
Great. So thank you again for the introduction. It's a pleasure to be involved in this endeavor to talk about not only clinical work, but also what drives clinical work, which is basic science. So it's always a pleasure for me to be involved in this effort of ADORE from the Cure Trust. So thank you again, Arvind, and good to see my other colleagues, Dr. Sosale, Dr. Reddy, and Dr. Sheshadri, and Dr. Kumar. So the topic that has been suggested that I discuss today is relating to hypoglycemia, and my lab is focused on mechanisms in the large sense of the word. So I won't go into too much detail as to the characteristics of hypoglycemia or the statistics that are involved in hypoglycemia, but address what we're going to do about it, because we still know that it's a problem. So we know that it's a major complication in both type 1 and type 2 diabetes. So just a couple of slides to make that case, and also to begin to give you some background on hypoglycemia. So you can see that among all the different complications in both type 1 and type 2 forms of diabetes, hypoglycemia stands out, as shown on this particular slide, providing us the rationale as to why we need to continue to work on understanding the mechanism, so that we can better treat individuals who have who suffer hypoglycemia as a complications in different forms of diabetes. So let me step back and give you a little bit of a primer, but not in great detail, as to what is the mechanism, right? So a leader in this field has been Phil Cryer, and I'm sure many of you remember Sam Dagogo-Jack, who trained in the Cryer lab, who also contributed to some aspects of hypoglycemia. So this cartoon, which was published in New England Journal of Medicine and has also made its way to a large number of textbooks and primers in diabetes, gives you an overview as to how the organism addresses low blood glucose levels. I don't want to go into great detail, but just make 2 or 3 points in this regard. So we know that both type 1 and severe forms of type 2 have the problem of hypoglycemia. And we now know that there are 2 or 3 pathways which are important in this context. Alterations in the insulin level, which can impact the beta cell, reduced insulin sensitivity, alterations in the parasympathetic system, especially in the context of enhanced epinephrine levels, can contribute to the aspects and the symptoms of hypoglycemia, and increased glucagon levels from a dysfunctional alpha cell in the endocrine pancreas. So I've just crystallized 3 aspects of hypoglycemia, which are the major areas of interest to understand the mechanisms. My own lab has been focused on alterations in the alpha cell. So I'll focus more on that aspect to argue what we have come to know and the reasons why we are focused on the alpha cell. So going back to the overall picture of alterations in the context of the alpha cell, we know that the mass of the cells in the islets, we all know that you have 5 different cell types in the endocrine pancreas in the islet. The major cell type, of course, is the beta cell. And we know that alterations in the beta cell mass can lead to alterations in the secretory demand of the beta cell, which can in turn lead to impaired beta cell function. And all of these have been related to oxidative and endoplasmic reticulum stress, also called as ER stress. And all of these have been published, supported by publications, including our own lab, to argue that the interactions between the stress pathways and the islet cell mechanisms that regulate to homeostasis are critical to maintain normal blood glucose levels. But there are a couple of arguments that have arisen over the last several decades to begin to pinpoint what could be the pathways or what we are missing in the context of understanding the causative roles for different factors in promoting hypoglycemia. So if one looks at the literature carefully, you can see that this table shows a number of studies from multiple groups, shown on the left, Rahir et al., Butler, and so on, have shown that there is a reduction in beta cell mass in these individuals with pancreas, with diabetes. So reduction in beta cell mass is a major component. So one interpretation of this particular series of studies is that the beta cells somehow are susceptible to metabolic stress, because we know that you have increased glucose levels, alterations in fatty acid levels, alterations in cytokines in advanced cases, and all of these can contribute to the behavior of the beta cell. And so is it possible that the beta cell is more susceptible to stress and begins to die, and therefore that leads to reduced beta cell mass? But what is also important to consider is what is happening to the alpha cell mass. And I just mentioned to you that the alpha cell plays a very important role in the context of glucagon secretion, which is important to maintain glycemia in hypoglycemic state. So if one looks at all the literature that we have so far in the context of alpha cell mass, there appears to be a relative increase or no change in alpha cell mass. So for the sake of this argument, I would say that somehow there's an increase in alpha cell mass, which contrasts to a decrease in beta cell mass when both the cell types are exposed to metabolic stress, which is hyperglycemia, alterations in free fatty acids. So the question is, why is the alpha cell somehow resistant to this metabolic stress? Does it develop some pathways which are important to maintain the cells? Do these mechanisms then promote alpha cell growth or increase alpha cell secretion, which in turn leads to dysfunctional glucagon response when it's confronted with hypoglycemia? So we took this outside the box approach to begin to understand, why is it that the alpha cell is less exposed to stress or less responsive to stress, in contrast to the beta cell, which just gives into stress and then you lose beta cells, right? This is the contrast between the two. So beta cells are more susceptible in contrast to alpha cells, which are resistant. And this is the difference in these two cell types, although the milieu in which they are sitting in is the same: hyperglycemia, increased fatty acids, and so on. So there's something about the alpha cell behavior which is telling us we should be focusing on stress responses. So going back to this paradigm, if we can argue what may be happening in the context of alpha cell mass changes, then we can begin to understand this pathway. We also did some experiments. Again, I know that Dr. Arvind pushes me not to give too much data, but that's what drives science. But I just want to summarize here to say that when you look at the response of the glucagon shown on the left panel here at different concentrations of glucose, 5.5 or 25 millimolar glucose, you see that the higher the glucose levels, and when you challenge these cells with TG, which is thapsigargin, which is a form of ER stress, the glucagon response becomes blunted. So we know that the alpha cell in the context of hyperglycemia is responding very poorly, and the panels on the right are all markers of ER stress, XBP1, BIP, ATF4. So I won't go into detail there, but just to argue that we showed that there is some kind of an effect here in the context of why they seem to show a dysfunctional response. So then we began to provide, so that's the rationale. The rationale is that an unchanged or dysfunctional alpha cell mass in type 1 or type 2 would argue for a differential stress response in the context of hypoglycemia. So what are the pathways which are important for the alpha cell stress response? So you can see that we've moved all our studies in the context of understanding the alpha cell pathways. So I want to introduce a topic here, CRISPR-Cas9 as a tool that we used for beginning these studies. I'll try to keep this as simple as possible without too much jargon, but I'm sure many of you are aware of CRISPR-Cas9, which has made news in different contexts. But in this particular context, CRISPR stands for clustered regularly interspaced short palindromic repeats, and this is recognized as an immune system in prokaryotes used to prevent infection by viruses called phages. So this tool has been recognized for several years now, the last 2 or 3 years, as a powerful way to do an unbiased screening approach in different systems. And just to mention that these two ladies, Jennifer Doudna in Berkeley and Emmanuel Charpentier from France, received the Nobel Prize in Chemistry in 2020 when they discovered CRISPR. So that's a big advance in the field, just to make a point that we are using state-of-the-art technology to address this. So how can we use this? So I gave you the background of the alpha cell is a dysfunctional cell type. We are using a CRISPR-Cas9 approach to begin to understand the different pathways that we can interrogate in CRISPR in the alpha cell. So shown here is a cartoon of what we did. Again, to keep it very simple, we use a CRISPR library. So essentially what we're doing here, simplistically, is we take alpha cells and we subject that to a CRISPR-Cas9 system after we introduce a stress response in the alpha cell. And then we begin to look by screening what pathways are distinct in the alpha cell compared to potentially other cell types. So that will give us some idea as to why the alpha cell behaves differently compared to the beta cell. And then we could use that information to develop a therapeutic target. So I just want you to realize that the long-term goal here is to try to understand how we can develop therapeutic targets to prevent hypoglycemia. And this is the science behind that. So typically people use a negative selection, but we have used the positive selection as an approach to begin to look at these different pathways. So the workflow of the study, again, without going into too much detail here, we use a library from the Broad Institute to look at a number of different small molecules. We develop a lentivirus library in the alpha cells. We transduce the lentivirus into the alpha cells, and then we subject the alpha cells to stress using thapsigargan, and then subsequently we begin to grow these back to confluence and then select out what are the cells which are still surviving this cell type. So I told you that the alpha cells are resistant to stress, right? I made that argument that too many alpha cells as opposed to too little beta cells in the islet in type 1 and type 2. So why is it that the alpha cells are surviving? So this workflow will identify those cells which are resistant to high levels of stress. So I'm just condensing 2 or 3 years of work with this volcano plot. So what we ended up with was several hits, what we call several hits in the context of the molecules which are important in regulating alpha cell function. So shown on the volcano plot is that it looks like a volcano. So essentially it gives you a set of molecules which are downregulated, which is shown on the left, or upregulated, shown on the right. And we use a system where we did replicates 4 times to show that the molecule that we are identifying is significant. So the blue circles gives you the 4 different replicates, again giving us the confidence that the molecules we're identifying are very significant. And then you have those green circles, which give you the 4 green circles, which show, again, the 4 different repetitions showing the same molecules and so on. So we ended up with a series of molecules, which gave us a clue as to what may be happening in the alpha cell in this context and begin to understand in greater detail. So I'm going to take you back a little bit to biochemistry here to show what exactly I'm talking about. So this is if you remember, physiology / biochemistry, the endoplasmic reticulum Golgi transport pathway important for intracellular protein trafficking. And you see a number of these molecules that come up here are shown. The SEC1 protein, which we identified in our own screen, is important because it plays a huge role in intracellular protein trafficking. So shown at the bottom here are the SEC proteins, which are important for ER function. So let me keep this very brief and say that our unbiased approach using the CRISPR screen identified a molecule in the endoplasmic reticulum transport pathway with the Golgi, which tells us that that particular molecule protein is important in the stress response in the alpha cell. So how can we learn more about this? So what exactly is SEC31A? It's a core protein complex which promotes the formation of vesicles. It's part of the outer layer of the core protein complex 2 or COP2. Its major function is physical deformation of the endoplasmic reticulum membrane and is important for selecting cargo molecules. So this protein has been identified many years ago and has been a subject of investigation in the context of endoplasmic reticulum stress. So we can begin to then look at the signaling pathways which are important in this context to show that some aspects of SEC31A are playing a role in cell death. So shown here is a Western blot. Again, I won't go into great detail here, but just suffice to say, let me see if this is working here. Yeah, so you can see that the pathway shows you a great detail of which are the different aspects of signaling proteins we're interrogating, but just focus on the cleaved caspase 3. So cleaved caspase 3 is a marker of cell death. So when one looks at alterations in SEC31, the protein identified in the endoplasmic reticulum, you take away that protein in a knockdown of this alpha cell. You can see that the amount of cleaved caspase 3 is significantly downregulated. And in contrast, the ATF4, which is a marker of ER stress, is upregulated. So I just want you to keep in mind that the alterations in cell death are playing a role in the context of SEC31A. I'm trying to see whether, yeah, this is working. So the second observation, again, very briefly, is that we found the SEC31A binds to the insulin receptor subunit in the alpha cells. So without going into great detail, you see this band here, which is the short exposure, long exposure, binds to the insulin receptor beta subunit. And when you knock down the SEC31A, you take away SEC31A, this binding is absent. So this is telling us SEC31A is linked to the insulin signaling pathway in the alpha cell. So it gives you the context of regulation of alpha cell biology with insulin receptors on the surface of the alpha cell. So we can do, again, a number of experiments to begin to look at this in great detail. We've now identified TCPTP, which is an important regulator of insulin receptor in the context of SEC31A knockdown. So how is this applicable to human cells, right? I'm sure you guys are saying, oh, this guy is talking a lot about biochemistry. And so we always have the long-term goal of trying to understand how this applies to human cells and how we can move this towards therapeutics. But you can't get away from basic science if you want to make an advance. So we went back to the lab and began to generate human alpha cells and ask what happens to the human alpha cells when you take away this SEC31 protein. So shown in this figure is from a manuscript that has been submitted for publication, which shows human alpha cells that we obtain from cadaveric donors. And we make pseudo islets from those. And these islets are rich in alpha cells. And we use these alpha cells for further studies that I just showed you in a cell line. So, for example, we take these alpha cells and culture them for a period of 7 days, and we introduce this lentivirus which has the SEC31A protein. And we ask what happens to these changes in SEC31A regulated function in these alpha cells. So again, shown here as an example of where you can use human alpha cells to form pseudo-islets and show lentiviral transduction. I just want to mention two data points here which are important. One is you're taking human alpha cells, and after 3 or 4 years of our work, we've identified the SEC31A molecule in the ER or the endoplasmic reticulum to be important. And we downregulate this by knocking down SEC31A. And then we look at what happens to markers of cell death. I told you cleaved caspase 3. So you can see that when you knock down SEC31A, the amount of cleaved caspase 3 is downregulated. So this tells us that the alpha cell becomes resistant when you manipulate SEC31A. So we think that the SEC31A molecule is an important target for therapeutic influence in the alpha cell, in the overall goal to find out why the alpha cell is dysregulated in hypoglycemic conditions. So let me conclude. I know that I'm running out of time here. I want to keep to time by showing you a cartoon where we have now realized that in the alpha cell, shown here, where you have the insulin receptor and you have the Golgi and the endoplasmic reticulum pathways, which are important in regulating different aspects of cell function. The effect on cell survival upon CR stress is regulated by SEC31A in the context of the unfolded protein response, or UPR. And the UPR is the way the cells will survive in the context of stress. But we also shown that SEC31A, which is in the endoplasmic reticulum, somehow communicates with growth factor signaling on the surface, for example, insulin signaling. So these 2 points argue for us to focus on SEC31A in the alpha cell in the context of how it regulates the alpha cell glucagon secretory response in the context of hypoglycemia. So I know that there's a lot of biochemistry there for a few minutes, but I just want to bring you back to what we want to do now. We want to identify the pathways that link this important molecule in the endoplasmic reticulum to insulin IGF-1 signaling pathways. And we want to extend these to dynamic studies in primary human alpha cells, for example, from those who are healthy controls, as well as those individuals who have got type 1 diabetes. So you can see that trying to look at hypoglycemia and trying to find a way to limit those individuals with hypoglycemia brings us all the way back to basic biochemistry and physiology, because you have to really do that. There's no getting around it. And we know that hypoglycemia is still a problem. So we can't just sit in the clinic and pray that hypoglycemia goes away. It will not happen. So I hope that I've convinced you that you really have to go back to basic science. You have to identify proteins. And the next feature for us would be to, how can we target? Can we develop small molecules which can influence SEC31A in the alpha cell? Can we develop an approach initially, obviously, in a small mammal like a mouse or a rat to show when they're exposed to hypoglycemia, can this molecule work? And then move to the human scenario and begin clinical trials. So I just want to end up by acknowledging the people in the lab, especially Kimitaka, who did a spectacular job over the last 4 or 5 years, taking on a very tough topic to address this issue. And as Dr. Arvind mentioned, I'm coming all the way from snowy Boston. I'm happy to take questions, and I hope that I have enough time. Thanks very much.
Rohit, can you hear us? Thank you. Thank you, Rohit. That was an excellent insight. For the first time, I'm listening to hypoglycemia from you. Been listening to all the beta cell talks and NFLD the last couple of years. A new insight and the new pathways of what you showed us today. I don't think I have any questions, but I'm probably in future we have some targets which you work on and maybe we'll have less patients, and we'll have some solutions to this, going back to biochemistry and physiology, as you mentioned. Any questions from the audience?
Rohit, can you hear us clearly now?
Yes, we can. Thank you.
Okay, so we're just asking the audience over here whether there are any questions. And whatever little few strands of hair I had, I even lost them after listening to your lecture. I mean, to be very honest, this was a lecture which was going well above most of our heads. Okay. But congratulations, because this is brilliant work. And then we all are extremely proud of you. I don't think most of us over here are clinicians. And I thought the postgraduates would come up and then ask some questions. I don't see anybody asking the questions. So that means Dr. Rohit's science is probably too ahead of our things. And I can see Dr. Lori Leffel, and I'm going to have a lot of questions to Dr. Lori Leffel later on. Dr. Lori, if you can unmute, do you have any questions to Rohit? We can't hear you.
Talk as usual, Rohit. Wondering if you see applications in type 2 diabetes with some of the oral agents that lead to hypoglycemia. It's in a setting where there are beta cells. And so are your targets for the alpha cell in an intact islet or not in an intact islet? So how would you view the molecule that you found in both settings?
Yeah, that's a good point, Laurie. And I think I started off by arguing for both type 1 and type 2. And as you rightly mentioned, there's a relative paucity of beta cells in the type 1. So one can envision that the alpha cell somehow is being dysregulated. But the same can be applied in type 2, because as I'm sure you're aware, you have elevated levels of insulin over a period of time, and the sensitivity of the alpha cell to insulin signaling is blunted. So there is, so to speak, insulin resistance of the alpha cell over a long period of time with patients, especially in patients with type 2 who have been subjected to high levels of exogenous insulin injections day in and day out. The resistance of the alpha cell builds up over a period of time. And we have simulated that in a rat model by haploinsufficiency of the insulin receptor in the alpha cell, but not interfering with the beta cell mass at all. And when you do that to simulate what happens in insulin-resistant conditions, the alpha cell is still dysfunctional. So one has a pathway which links up to the insulin receptor, and the fact that the SEC31A protein binds to the alpha receptor, the alpha cell insulin receptor's beta subunit, provides additional evidence in that context.
I just would wonder if there would be potential different families of molecules that would be more effective in the setting with the intact. It's still a dysfunctional islet, but an islet that is under the influence of insulin.
You're right. I think looking at different molecules in the two different models is what we want to do, because we don't presume that both of them are going to work in both the models. So that would be the next step. Yes, perhaps the Beatson.
Thank you, Dr. Rohit. Thank you so very much. And sorry, we had to wake you up very early, and we had to wake up Dr. Lori Leffel also. I think in person, I'm thanking Dr. Lori Leffel also for having agreed to come and speak to all our audience over here. And this is going to be a very clinical talk. And I heard Dr. Lori speak the same topic at the IDF, and it's about the Dynamo study. And I'm sure you will have a lot of questions after this Dynamo study. And now I request my co-chair, Dr. Sanjay, to introduce Dr. Lori Leffel to the audience, please.
Dr. Lori Leffel, thank you for being with us. I listened to you to the same talk at the IDF, but I want to listen to it once again. Dr. Lori is the Chief of Pediatric Adolescent and Young Adult Section at the section for clinical behavioral and outcomes research, and professor of pediatrics at Joslin Diabetes Center. She's been an advisory on many international pediatric and adults in society, like the ISPAD, and also been involved with the AD as member of the Boston Leadership Board, past president of National Board of Directors Committee for Professional Practice Guidelines, co-chair on work group on transition, and past chair of ADA's Youth Strategies Committee. She's member of the ADA Pathwork Mentor Advisory Program, also an editor for Diabetes Medicine. She received the ADA 2015 Outstanding Physician Clinician Award, Greater Boston Chamber of Commerce 2016 Pinnacle Award, and 2016 University of Miami School of Medicine Hall of Fame Award. This is a brief of Dr. Lori Leffel. Over to you, Dr. Lori, for your talk. Thank you.
So thank you very much for that kind invitation. Let me just get my slides set up here and make sure you can all hear me. Can you all hear me and see my slides?
Yes, we can see the slides. We can hear you also.
Let me just move this banner a little bit. So, okay. So I'm really happy to present this lecture today. Appreciate the invitation from the chairs. And I'll give an update on the treatment of type 2 diabetes in youth, specifically focusing on the DYNAMO study. And let me just jump right ahead. So I think here are my disclosures unrelated to the current presentation. I think this audience is well aware of the increasing and extremely important global prevalence of diabetes. Recent data from IDF publications and others have shown that the global prevalence of diabetes is exceeding 10%, with over 500 million people globally, adults affected with diabetes, and that's expected to rise to over 750 million people affected by diabetes by the year 2045. And this doesn't just affect adults. There is youth onset type 2 diabetes, and currently recent data suggests over 40,000 youth with type 2 diabetes. In the US, we have 6,000 new cases per year with type 2 diabetes, based on data from the SEARCH study, and we have approximately almost 40,000 prevalent cases of type 2 diabetes in the United States. So I think you're aware of this global problem. So what do we have to do? Well, in recent decades, due to the substantial increase in type 2 diabetes, we recognize it's derived from the epidemic of childhood overweight and obesity, inactivity, unhealthful living. The challenge here is that we know in youth onset, compared to adult onset type 2 diabetes, insulin sensitivity is reduced by more than 40%, and beta cell function deteriorates more rapidly, placing youth at risk for worse glycemic control and premature diabetes-related complications. The Today study, which I was fortunate to be a part, I was the principal investigator at the Joslin site. The Today study showed that among the participants with the youth onset type 2 diabetes, after living with diabetes for a little over a decade, the cumulative incidence of complications, hypertension, dyslipidemia, kidney disease, eye disease, exceeded 50%, with hyperglycemia being a significant risk factor for these morbid and potentially mortal complications, and these are young people. So we recognized and are grateful for the fact that over the past few decades, there are many new therapies across many different drug classes to treat diabetes in adults, type 2 diabetes in adults, to control their glycemia. In contrast, there's an extraordinary shortage of oral treatments for type 2 diabetes in youth, with only metformin and along with injected insulin approved to treat type 2 diabetes in youth until the recent approval of GLP-1 analogs, and I'll quickly review that in one slide. Thus, there is an unmet need for additional oral therapies for the treatment of type 2 diabetes in youth, given its increasing numbers. And this slide reviews the major recent studies of therapeutics in pediatric type 2 diabetes. And these are studies that look at GLP-1 analogs, SGLT2 inhibitor dapagliflozin, and the DPP4 inhibitor sitagliptin. And what's remarkable here in the pediatric studies, as people are aware, is it's a global challenge to get these studies completed. These studies have included only 72 to 220 participants. And the one study that evaluated an SGLT2 inhibitor, dapagliflozin, and I was part of this trial as well, included only 53 youth who were really of the pediatric age group, ages 10 to 17. Nonetheless, these were really important studies, and they led to the approval of three GLP-1 analogs in the US. Two GLP-1 analogs are approved by EMA, with the third expected early this year. And EMA has an approval of dapagliflozin in the pediatric patients, and no SGLT2 inhibitors are approved in the US. Well, how did we embark on the DYNAMO study? Well, the SGLT2 inhibitor empagliflozin and the DPP4 inhibitor linagliptin are well-established treatments for adults with type 2 diabetes. EMPA has shown clinical benefits in patients with type 2 diabetes and cardiovascular disease, heart failure, and chronic kidney disease. Data from dose finding studies in pediatric participants using these ages have shown that the doses in pediatrics match those in adult studies, therefore supporting the investigation of both EMPA and LINA in placebo-controlled trials to assess their efficacy and safety in these youth with type 2 diabetes. And these agents also have good safety profiles, although there are rare safety signals known to be associated with these agents, such as DKA and necrotizing fasciitis with SGLT2 inhibitors and pancreatitis with DPP4. So clearly it's important that not only do we assess the efficacy of these agents, but really evaluate their safety. And this is why we embarked on the DYNAMO study. So the DYNAMO study had a major objective to overcome the past challenges that we have observed in studies of youth with type 2 diabetes. As most studies, as I shared with you, have findings in less than 200 participants. And many studies had been started and failed to go to completion because of inadequate recruitment. So the DYNAMO study was designed to overcome recruitment challenges and included a novel study design, which I'll spend a little bit of time in sharing with you. Thus, the main objective of DYNAMO is to assess the efficacy and safety of a dosing regimen with empagliflozin with a potential dose increase from 10 milligrams to 25 milligrams, along with a single dose of linagliptin, 5 milligrams, both compared to a shared placebo group. So these are two independent comparisons, the EMPA versus placebo, and then the LINA versus placebo. So a very strategic study design, so you reduce the need for two separate studies and increased participant size, which has been the global challenge. And in fact, this was a global study across 4 continents, 15 countries, 108 initiated sites. So we were really pleased to see the large impact of the global participation. These are major inclusion and exclusion criteria. Youth had to be 10 to 17 with type 2 diabetes, A1C 6.5 to 10.5. Patients could be treated with diet and exercise plus either metformin or basal insulin or multiple daily injection insulin. Those who could not tolerate metformin could be on diet and exercise alone, but there were very few, as I'll share with you later. You had to have no evidence of beta cell autoimmunity, and you had to have measurable C-peptide levels, and this was done in the non-fasting manner because that's easier to do to get these young people in for study visits. In addition, there was an exclusion of individuals with DK in 8 weeks prior to screening, diagnosis of monogenic diabetes, and impaired renal function. I'm going to spend a little bit of time on this study design because it's quite unique. After a screening period, patients underwent a 2-week run-in period given placebo to ensure they could take study medications, and then they underwent randomization, a blinded, double-blinded randomization in a 1-to-1-to-1 group to placebo, 5 milligrams of lina or 10 milligrams of empagliflozin. At 12 weeks, there was A1C was obtained, and for those unable to achieve an A1C of under 7% at week 12, there was a second randomization aimed at escalating these individuals on the EMPA group who were originally randomized to 10 milligrams to be re-randomized to either 10 or 25 milligrams of empagliflozin. This actually wound up including 24 individuals in the re-randomization to either 10 or 25 milligrams. So it's small numbers here. But I share with you, this was a way to be creative, to look at different dosing regimens in a very parsimonious study design. At the end of the primary efficacy endpoint at 26 weeks, there was yet another randomization of those who were initially assigned to placebo, re-randomized 1:1:1 to Lina 5, EMPA 10, or EMPA 25. And I will say that everything always remained double-blinded. Everyone received a re-randomization package at 14 weeks and at 26 weeks. And this was done using interactive response technology. What you will see is that throughout the series of slides, placebo will appear in gray, linagliptin appears in dark blue, and the empagliflozin colors may change a little bit because what the primary outcome is what is being called an empagliflozin dosing regimen, where we're looking at EMPA, whether it's 10 or 25, and then there are a few comparisons, secondary comparisons of EMPA 10 and 25. So let me take you through the rest of the study design. And again, we went out to 52 weeks so we could get additional safety analysis. Primary efficacy endpoints was pooled EMPA versus placebo, and the second Lina versus placebo. Again, like you can view them as separate studies, and the secondary comparisons with the EMPA responders on the 10 milligrams, as well as those who didn't respond to 10 and were up titrated to 25. And then the other is the EMPA responders to 10, who were then added to the non-responders to 10 who were re-randomized to 10 milligrams. And we consider these as the secondary comparisons. In addition, there was secondary endpoints of fasting plasma glucose, body weight, and blood pressure. The statistics used a primary analysis of a modified intention to treat sample, and included all randomized participants treated with at least one dose of study medication who had a baseline A1C. On and off treatment A1C data at 26 weeks were included in the primary analysis, and missing off treatment A1C data were replaced by multiple imputation using a washout approach. The primary endpoint was analyzed by an ANCOVA model with baseline A1C as a continuous covariate with categorical covariates for treatment, which group were they assigned to an age group. And these were stratified into those under 15 and those 15 to under 18 years of age. Let the next three slides here go over the baseline characteristics. And here you can see sort of more clinical characteristics in these three groups. Again, the placebo, and I'm calling it again EMPA pooled, and linagliptin, they were really well matched according to baseline data. Average age was around 15, about 60% were female. The majority were post-pubertal. And you can see pediatric type 2 diabetes youth, although we have pediatric in the title, they are very large people. Their average weight was about 100 kilograms. Their BMI was well into the obese category, 36 or higher. And in fact, over half were categorized as having class 2 or 3 obesity. Blood pressure and kidney function were as noted and were reasonably fine. Clinical characteristics with respect to diabetes, a third had duration of type 2 less than a year. In type 2 pediatric youth, we really have incident cases, not prevalent cases as you see in adults with type 2 diabetes. And about a quarter or so had type 2 diabetes for more than 3 years. Average A1C was around 8%, and fasting glucose was about 150 to 160. Of note, I want to say in this trial, about 80 to 90%, just roughly about 90% received metformin or metformin plus insulin, and a fairly large proportion were already on insulin in this trial of youth with type 2 diabetes, ranging from 42 to 40% to 48%. And only 9 participants, this is shown as percent here, but only 9 participants were not able to tolerate metformin. Last, other demographic characteristics show that about 2/3 were from North America, but really a global distribution. About 50% were white, and about 60% were non-Hispanic. But it surely represented the globe and represented racial and ethnic groups. Let's just see what the endpoints were. And again, as a reminder, because of the complex study design, the primary endpoint at 26 weeks is a comparison. The first one I'll go through is the empagliflozin pooled group versus the placebo. And here you can see an empagliflozin pooled will appear in red on these following slides. At baseline with the A1C around 8, then randomization, you can see there was an initial substantial drop in A1C by 4 weeks in the EMPA pooled group and a sustained improvement in the A1C in the EMPA pooled group with the consistent rise in A1C in the placebo group. And in fact, this was a significant adjusted mean change from baseline in A1C favoring empagliflozin pooled group of a decrease of 0.84%. This is both clinically relevant and statistically significant. So we are thrilled that we can have a new drug for pediatric type 2 diabetes. Now let's take a look and see how does the EMPA pool group perform over time. You can see at the end of the 26 weeks, again, there's no longer a placebo group from weeks 26 to 52 weeks, but you can see that that improvement in empagliflozin remains as the 52-week A1C value in the EMPA pool group remains substantially below that seen in the placebo group at week 26. Now let's try to see what we can compare between those who got empagliflozin 10 and those who then were re-randomized to empagliflozin 25, although we have to recognize that analysis is susceptible to outliers and have to be cautious in evaluating what it may mean. And to just remind you of, again, the complex study design, we did a separate comparison here that at week 42, the non-responders to EMPA-10 were re-randomized to either EMPA-10 or EMPA-25, and the left side of this slide depicts the comparison of the EMPA-25. The right slide depicts the comparison of those who failed on EMPA-10 and were re-randomized to EMPA-10. And again, I will share with you on the next slide some of the methodology, again, quite unique and what allowed the Dynamo study to be completed in the pre-planned 4-year time period, despite the COVID pandemic. This analysis included a weighted ANCOVA with the combined empagliflozin subgroups either achieving an A1C less than 7 at week 12, so they succeeded on the EMPA-10 and they were given a weight of 1, or those were re-randomized to EMPA regimen of interest, and whether it was those re-randomized to 25 or those re-randomized to 10, and they were given a double weight because, again, remember that sample was cut in half because they went either to 10 or 25 milligrams. And those patients not randomized to the EMPA regimen of interest, for example, those looking at EMPA 25 now, those who happen to be randomized to 10 were given a weight of 0 and not counted because we double counted those who were reassigned randomly to 25. This is called an inverse probability weighting, and it accounted for the treatment reassignment of just half, the 50% of the re-randomized EMPA groups at week 14. That's why you double it and give the weight of 2. Very unique and important approach to study design and study samples from populations that are difficult to recruit for, but need ongoing clinical investigation. Well, what did we find? And again, we need to be cautious. Our findings were a little unexpected, but because of the small sample size, we know there's susceptibility to outliers. And the left panel shows those who were unable to achieve A1C less than 7 at 12 weeks, and that's called the EMPA non-responders who got 25 milligrams. They had an adjusted mean change in A1C compared to placebo of a drop in A1C of 0.52 compared to placebo, although this was not statistically significant. Those who failed to achieve 10 at week 12 and re-randomized again to 10 at week 14 did have a drop in their A1C with the adjusted mean change of negative 1.18, which was statistically significant. Again, we have to be cautious because of the small numbers and susceptibility to outliers. And indeed, there was an outlier in the group re-randomized to 25. And again, I highlight 13 patients re-randomized to 25 and only 11 re-randomized to 10. And now let me just go and show you, sorry, I hope I didn't go backwards here. Okay, so here, let's see how did these people fare over the 52-week period of time. Remember, they were re-randomized at week 14 to EMPA 25 in blue, EMPA 10 in purple, and again, it included the comparison through week 26 and out to the safety endpoint at week 52. And here you can see over the second 26 weeks of the trial, the two EMPA groups pattern of glycemic control really appear closer and have much greater overlap. So overall, you can see empagliflozin maintained some improvement in control with a little bit of deterioration, which tends to be the natural history in youth onset type 2 diabetes. A cleaner comparison of EMPA 10 versus EMPA 25 comes from the initial placebo group, which was re-randomized at week 26 to either 10 or 25 milligrams. So they were in a group that was biased by already not doing well on a drug from baseline. So this is a cleaner group. They're on placebo at 26 weeks, and then they receive either EMPA 10 or EMPA 25. Here you can see what we would have possibly expected as a more, it's certainly a cleaner comparison, but you can see that the empagliflozin 25 group, along with the 10 milligram EMPA group, both have a drop in A1C by 4 weeks, and out to week 52, you can see that the EMPA 25 has a slightly lower A1C than does the EMPA 10 milligram group. So we just share these as secondary comparisons to get an understanding of what dosing regimen we may need, but EMPA overall we know has been beneficial. Well, let's jump to linagliptin. Again, we remember the linagliptin is compared independently to the placebo group. Linagliptin is in blue and placebo is in gray. And here you can see that there's a modest improvement in A1C by week 4, but out to week 26, you can see the A1C rises in the linagliptin group and it rises in the placebo group from baseline. And again, this highlights the challenge of youth onset type 2 diabetes as ongoing beta cell challenges and frankly, ongoing beta cell failure with deterioration in glycemic control, as I shared at the beginning. This is the adjusted mean change from baseline in A1C comparing the Lina group with the placebo group, and Lina again in blue. There was a drop, a lower A1C by lower difference adjusted from the baseline of 0.34%, but this was not statistically significant. Here we take the Lina group from baseline out to 26 weeks all the way out to week 52. And again, you see ongoing deterioration in glycemic control. Here is the placebo group that was randomized at week 26. And again, you can see the ongoing deterioration in glycemic control, despite this modest improvement at week 4 or 6. And again, this is not too different from the sitagliptin data that were recently published. The DPP4 inhibition in youth onset type 2 diabetes does not seem to be an efficacious treatment to maintain and improve glycemic control in youth. Well, let's take a quick look at secondary endpoints. We'll look at fasting glucose. And again, consistent with the mechanistic action of SGLT2 inhibitors, you can see comparing an adjusted mean change from baseline in fasting plasma glucose absolutely statistically favors empagliflozin with a 35 milligram per deciliter or 2 millimolar drop in their fasting plasma glucose compared to the placebo group. The linagliptin was only 5 milligram per deciliter lower of 0.3 millimolar, again, not statistically significant. Fasting plasma glucose was statistically significant and again falls within the, as we'd expect, the mechanistic approach of SGLT2 inhibitors. Body weight changes were not significant, but again, there was a suggestion of favoring empagliflozin compared to placebo, and linagliptin showed no benefit. Again, not statistically significant, nor was there a statistically significant difference in systolic blood pressure shown here, nor diastolic blood pressure. But again, you see the modest suggestion of lower numbers in the EMPA group. Let's take a quick look at safety outcomes. And again, we're looking at safety outcomes up to the 26 weeks when you have the three groups of placebo, EMPA pooled, and linagliptin. And here we see any AEs leading to discontinuation, serious, but all non-fatal AEs, and they're very well matched across these three groups. And this is the important safety comparison because there is a placebo group. This group shows AEs of special interest, and the things I want to highlight here is that there was a slight increase in hypoglycemia-related AEs, which is not unexpected in the groups that were receiving active treatment, either EMPA or LINA compared to placebo group. Notably, there was no diabetic ketoacidosis in the EMPA group, and not unexpected, there was an increase in urinary tract infections, which might be related to maybe genital urinary tract infections and maybe some misclassification of what those infections were, but you see that in the EMPA group. Most importantly, the safety profile in the pediatric patients matched the recognized safety profile in adult studies. Here's the summary of adverse events up to week 52. We have no longer a placebo group, so we're looking at EMPA pooled versus LINA, and again, you see very well matched between these two groups, and nothing is unexpected or life-threatening. And again, you see here the slight increase in urinary tract infections, which I again highlight could be genital urinary tract infections and some misclassification in the AEs. And again, you don't see any DKA in the EMPA group, and lots of these other AEs that were serious were really not related to study drug, like a motor vehicle accident or suicidal ideation leading to hospitalization. So let me summarize, because we were very proud of our findings that Dynamo showed that an EMPA dosing regimen provided clinically meaningful and statistically significant reductions in A1C and fasting plasma glucose in youth with type 2 diabetes. The outcome at week 26 demonstrated this, again, clinically relevant and statistically significant drop in A1C, a lowering of A1C of 0.84% versus placebo. The safety profile of EMPA compared to that in adult studies was favorable and certainly comparable. And there were no episodes of DKA in Dynamo. While linagliptin was well tolerated, it did not provide significant improvements in glycemic control. Well, what have we learned and what can we take forward is achieving target glycemic control in youth with type 2 diabetes remains challenging. And thus there's a need for additional oral therapies. Although insulin and GLP-1 receptor agonists can aid in efforts to improve control, both require injection, which may impact adherence. Dynamo study results support management of type 2 in youth with the oral SGLT2 inhibitor empagliflozin, which can provide effective lowering of A1C with a good safety profile. And we hope there will be the possibility for future cardiovascular and renal benefits, as recently coming out from many studies, even as late as this fall from the nephrology meetings. So future clinical observations can assess the effect of empagliflozin on the durability of glycemic control in youth onset type 2 diabetes. I certainly want to recognize the study participants and families, the steering committee members who I worked with closely, and all the coordinating and local study staff who make up the entire Dynamo study group. And I know I went a little bit over, it's just complicated study design, but I do have a little bit of time for questions if the chairs will allow that. But thank you for your time and attention.
Hi, Dr. Lori. Thank you so much for a wonderful talk. I have one question for you. Why do you think, can you hear us? Yes, first of all.
Yes.
Yes, okay.
Yes.
Why do you think we did not see as much of a response in the linagliptin arm compared to the empagliflozin arm? Do we have any theories on this?
This is similar to the data published on sitagliptin this past year. I think it is a modestly helpful drug in adults with type 2 diabetes, but certainly doesn't have the same glycemic efficacy that other classes of agents have. And the beta cell function in youth onset type 2 diabetes is fragile and fleeting. and their insulin resistance is extraordinary. You basically just don't have enough, I think, residual endogenous insulin to see the impact of the DPP-4 inhibitors would be my speculation, but certainly would welcome any comments from the audience here.
Thank you. I see Dr. Rohit raising his hand. Can we see him on the screen? Is it possible for someone from the IT to get Dr. Rohit on? He has a question.
Yeah, Laurie, that is a great talk. Can you hear me?
I can hear you. I can see your great picture.
Yeah, for some reason the audio is not working. But yeah, that is a great talk. So my question circles back to hypoglycemia. We heard that sitagliptin can lead to hypoglycemia in some instances. So in this trial, did you guys see any inclination in that
Yes.
context?
There was, in both the groups that received active treatment, whether it was EMPA or sitagliptin, there was an increased rate of hypoglycemia compared to placebo. There were no major severe hypoglycemic episodes, but there were more reported episodes of hypoglycemia and meter documented low glucoses. But again, remember, this sample included nearly 50% on insulin at baseline. So that also highlights the extraordinary fragility of the beta cell in these youth onset type 2 diabetes. So you're already on multiple agents. They're almost all on metformin, about 90% on metformin, and nearly half are on insulin. So you're seeing the increased hypoglycemia when you're adding another agent. As you know, many times you need to be on dual and triple therapy. We learned in the Today study that you need more than one drug.
Was there any data on glucagon at all in that context?
No, we don't. Great question. No, we have no. Great question.
Thanks.
Dr. Laurie Leffel, I don't have too many questions. Can you hear me clearly?
I can hear you.
Let me change
That's
it.
better.
I think this is better. This is the microphone that Dr. Bhavna used. One off-label question. As a pediatric endocrinologist, have you used sulfonylureas in type 2 diabetes below the age of 18? Because we now know that DPP-4s don't work, whatever may be the reason. But have you tried sulfonylureas and seen any success?
So we rarely use those agents. We did study them many years ago, and highlighting the challenge of studies in youth onset type 2 diabetes. This was a study that never came to completion because there couldn't be enough. There was not enough enrollment. So you study to assess efficacy, safety, and you have oversight to ensure studies can go to completion unless there's futility. And there was really futility in completing the study. And we don't use many sulfonylureas because we certainly know the fragility of these beta cells. And it's basically, you already have a failing beta cell mass in type 2 youth onset. And if you're going to give them sulfonylurea, you're likely going to challenge that even further. And you're not even handling the primary substantial insulin resistance you see in these youth. So we don't use it very often. No question, it's less expensive, but it also leads to hypoglycemia, and many of these youth are on insulin.
Yeah. Do you see in the years to come usage of metformin along with empagliflozin or cana in type 2 diabetes in young?
I think probably you need dual therapy. What we learned in the Today study was that the group that did the best was the group randomized to, everyone was on metformin in the Today study. You got either metformin alone, metformin and intensive lifestyle, or metformin and rosiglitazone, to refresh everyone's memory here. The group that was significantly better was the group that got rosiglitazone and metformin. And we do not use rosiglitazone in kids anymore. So given the challenges with the
Thank you so very much, Dr. Laurie, and I think thanks from all of us back in Bangalore, India. We made you get up so very early in the morning. I know Dr. Lara Jacobson is waiting there, and I request Dr. Bhavna to take over from now and introduce Dr. Lara.
And let me say good morning to Laura, because she and I are on calls often together. Good morning, Laura.
Hi, Laurie.
Thank you all.
Thank you, Dr. Laurie. We'll move on to the next talk now. And to speak on progressing towards prevention and, giving us views on how we could perhaps one day prevent type 1 diabetes. We have today with us Dr. Laura Jacobson. She's an assistant professor and a pediatric endocrinologist at the University of Florida. She's also a clinician who cares for children with endocrine disorders in addition to just diabetes. And she performs with clinical practice, translation research in the field of diabetes. She also knows ASL. I know just one word in ASL, Dr. Laura. You can help me with that later on. So I'm trying to teach my toddler ASL to communicate. And Dr. Laura is also been working on improving the lives of children and their families with diabetes, with all aspects of day-to-day life. And over to you, Dr. Laura, to talk about prevention of type 1 diabetes.
Thank you so much. I'm very excited to be here virtually today and share with you all just a little bit of my kind of experience regarding the prevention of type 1 diabetes. So I, as you said, am in the University of Florida. I'm over in Gainesville, Florida. And we really focus a lot here and throughout the country on not only intervening in the time of new onset type 1 diabetes to try and augment that autoimmune process, but also earlier in the disease. So I wanted to talk today about our progress towards preventing or delaying type 1 diabetes and how we can learn lessons from other time periods in the course of type 1 diabetes. I have no disclosures. So what I want to talk about are these key areas today. So keys to prevention for type 1 diabetes, and that it also involves definitions of what we mean when we say prevention. So when we talk about prevention of type 1 diabetes, we'd love to say we give one therapeutic and that results in someone never getting type 1 diabetes. That's because of the complexity of the pathophysiology of type 1 diabetes, that is very unlikely. Right now, what we're able to do, and I think where we can really push the field forward, is in delaying the onset of type 1 diabetes. I think most parents and patients would agree that if you can have 2 or 3 extra years without type 1 diabetes, it makes a huge difference, especially if you're a young child or a teenager, when it's already difficult to manage type 1 diabetes by yourself or with your family. So following that, I want to talk about how we can intervene in this process and when the best time and which therapeutics may be the best to intervene in this progression towards type 1 diabetes. There are a lot of barriers to this that I wanted to bring up, but also celebrate some of our recent advances in the field and talk about what I think are the next steps to continue this work. So keys to prevention of type 1 diabetes really involve these 3 areas. So if you think about it from people with established type 1 diabetes, you want to not only stop that autoimmune process, which we know is the underlying pathophysiology, but we also want to protect any remaining beta cells that are present. So depending on where you are in the spectrum of progressing towards type 1 diabetes, you may have a lot of beta cell mass that's present, or you may have lost a lot of it. So we want to have therapeutics in combination with our autoimmune therapies that can also preserve those cells that are present. And then for people who have established disease of a longer duration, you need to think about therapies that regenerate beta cells. I'm not going to focus on that today because that's not quite an area that is of biggest focus in preventing disease, because a lot of patients who are early in the disease course still have a lot of functional beta cell mass. So in that new onset or prevention space, we really want to focus on these 2 areas I've circled in orange, trying to halt the autoimmune attack and protect existing beta cell mass. So what are some mechanisms that we can try and target in each of these arenas? So again, I'm in the upper right, I'm not going to talk about beta cell regeneration with islet transplants or stem cells that differentiate into beta cells, although there's been a lot of exciting work on that. Vertex company here in the United States has made lots of great advancements and has therapies out in clinical trials. So very exciting space to keep watching. But what I want to focus on today is actually mostly up in the upper left-hand corner, talking about immune therapies. So these are different drugs, mostly that are repurposed from other diseases to help us augment the immune disease pathophysiology. So we want to augment the immune response by giving different immune therapies. Also, a really exciting area is antigen-specific immune therapies. So I'll go over later how that mechanistically can work. And then cell therapies, we also think is a very exciting area where you can implant or engraft cells into the body that can then work with the autoimmune process and try and augment or interdict in that process. So moving on to what would be the best time to treat someone who is progressing towards type 1 diabetes. And what we need to talk about before we can figure out the best time is what have we learned about this pre-type 1 diabetes time period? So we have, through work done by Type 1 Diabetes TrialNet, International Clinical Trial Consortium, we have discovered and tried to put into the literature these stages of type 1 diabetes. So these are what we think is the process that leads to type 1 diabetes. So I'm actually going to start at the far left of this slide. We know that most individuals who develop type 1 diabetes do have some genetic risk. So specifically to the HLA region in the genetic makeup, but not everyone has genetic risk. Some may have minor risk alleles, some may have these more major HLA risk alleles. But what we often see is this progresses from genetic risk towards immune activation. So you start to get some kind of immune response where your lymphocytes or T cells have started to infiltrate into the pancreas, or the pancreas sends off a signal somehow that it's not acting appropriately and the immune system comes in and targets it. And this results in an immune response that you can either measure by autoreactive antigens, by autoreactive T cells, or what we all know very well are autoantibodies. So these are antibodies that are targeted against antigens in the beta cell in the pancreas. And these are specific for type 1 diabetes and can be a marker of disease. So we have learned that even though people with type 1 diabetes and who are at risk have these autoantibodies, they're not doing any action that's destroying the pancreas. They're just a marker of disease that's going on. So once someone has developed these autoantibodies, we can predict with birth cohort and long-term studies that their risk of type 1 diabetes goes up greatly once an individual has 2 or more of these islet autoantibodies. So once you have 2 islet autoantibodies, that's considered stage 1 of type 1 diabetes. So we already consider that disease because the risk of progressing to type 1 diabetes, if you have 2 or more autoantibodies, is greater than 70% in your lifetime. So we consider that all the spectrum of disease, and it helps us really focus regulatory agencies in helping us develop therapeutics for these stages. If we progress a little bit closer to clinical disease, we progress to stage 2, where you still have 2 or more of these islet autoantibodies, but you also have abnormal glucose. So dysglycemia with a fasting blood sugar or a 2-hour glucose that's elevated on a oral glucose tolerance test. And that is a sign that you are much closer to the onset of clinical type 1 diabetes, or stage 3. So stage 3 type 1 diabetes is what we all classically think of. You have someone coming in with acute hyperglycemia, they're symptomatic, they may or may not be in DKA, and we consider that stage 3 of type 1 diabetes, classically like a new onset time period. And then beyond that, you have long-standing type 1 diabetes, which again, because of that loss of beta cells over time, is going to be not amenable to the same therapies. So when we think about how we want to target the individuals who have this risk, like say someone has 2 autoantibodies and they have normal blood glucose right now, what therapies should we start with to potentially interdict in this process? And the best way to start thinking about it is, well, what is the pathophysiology that's going on in the beta cell, in the immune system, that we can target with a therapeutic? So in simplistic terms, we have the beta cell here, And we have lymphocytes. So this is a cytotoxic lymphocyte, usually a CD8 T cell that does the attacking and destruction of beta cells. So we can think, great, let's interdict in this specific process. Often what we've all learned, though, is the immune system, especially in type 1 diabetes, is incredibly complex. And it really makes it much harder to interdict in this process. But we do have more areas to target. So not only do we have these cytotoxic T lymphocytes, we also have other effector cells that are being activated and recruiting other inflammatory cytokines and other cells to the pancreas. We have B cells and dendritic cells and other antigen presenting cells that are activating these T cells. And what we know is this is all supposed to be in balance with regulatory T cells shown here in the bottom. So our immune system works great if we have a balance of attacking T cells and regulatory T cells. That's how we help fight infection. But if that balance becomes disrupted, then we may have autoimmunity develop where we're attacking too much of our self antigens because our body, for some reason, has decided that the beta cells in the pancreas are dysfunctional or are showing that they should not be there anymore. I also show on the upper left-hand corner that we receive a lot of our training of our immune system through exposures that we get either from our skin or through our intestinal mucosa. So we get a lot of our immunity from these areas. So these are all potential areas we can target to try and augment this disease. So we published a paper several years ago that really tried to summarize some of the therapeutics that are available in these areas. So this really focuses on therapies that have been used in the new onset time period. So people with type 1 diabetes newly diagnosed, and you can see that each of these cells that I was talking about can be targeted with a specific therapy, either an immune modulatory therapy, a cell therapy like Treg transfers, or antigen-specific and beta cell protective therapies. But now, what specific therapies have been used in the prevention space? So if we think about the stages again, we often take our therapeutics from the new onset space to the prevention space. And that actually classically looks at two areas. It looks at prevention after you have autoantibodies and prevention before you have autoantibodies, where you just may have genetic risk or a relative with type 1 diabetes. So if you look in this primary prevention space before you have autoantibodies, these are called primary prevention therapies, and several have been used over the years. So what we have found is that we want to use low risk treatments in this time period because the diagnosis of type 1 diabetes is less certain. And it's more based on genetics and exposure because we haven't had that activation of the immune system yet. However, a lot of these therapies are not very strong or effective that we found in this primary space. There are specific subgroups of people that have been in the FRIDA study in Germany that may respond to oral insulin. There's also some effect on autoimmunity in insulin-free or bovine insulin-free formulas, but nothing that's been a sure bet in this early time period to delay or prevent type 1 diabetes. So now if we want to move on to therapies that are less about exposures and more about halting that autoimmunity, that's when we get into what people commonly think about as preventative therapies in type 1 diabetes that's related to secondary prevention. So these are therapies you give to someone who already has autoantibodies, whether they have dysglycemia or not, depends on how close they are to getting type 1 diabetes, but this is what people classically think of. And there are ongoing cell therapies where people are given their own cord blood to see if that cord blood, which has a lot of regulatory, highly functional regulatory T cells, can increase the tolerance in someone's immune system and kind of counteract that effector or cytotoxic profile. So that's ongoing and will be exciting to see. There's also been probably 7 or 8 antigen-specific therapies targeting insulin. And several of them have been very large, and the overall outcomes have been negative. So we haven't had in a large group of participants oral insulin or intranasal insulin or subcutaneous insulin prevent the progression to type 1 diabetes. And again, this insulin is being used to tolerize the immune system to this antigen, not to lower blood sugars. We're not giving it to augment glucose. We're giving it to tolerize the immune system. There were 2 large studies, the DPT-1, Diabetes Prevention Trial Type 1, and the TrialNet oral insulin study that did show subgroups within the cohort that did have benefit from oral insulin, but not the entire cohort that the study was powered for. So I do think there is a role for these very low-risk therapies, but it's not, again, a slam dunk that helps us move the field forward at this time. What has been really exciting is that there are immunomodulatory therapies that are more likely to have more effect on the immune system. So starting from the bottom of this list, low-dose anti-thymocyte globulin is a polyclonal T-cell specific targeting therapeutic that is just a trial we're starting because it's been successful in the new onset space. Hydroxychloroquine, as everyone knows, is used to treat malaria, and it's had some glycemic side effects that have been seen that were beneficial. So it was tried in type 1 diabetes patients at risk for disease. This and abatacept, which is a T-cell co-stimulatory inhibitor, neither of those 2, abatacept or hydroxychloroquine, showed any effect in preventing type 1 diabetes. But teplizumab, the drug on the top that people may have heard about in the news, is a specific monoclonal antibody against the CD3 receptor, which is specific to T cells, specifically effector or activated T cells. And that drug has shown a delay in type 1 diabetes, which I'll show on a later slide. So going into the challenges, I just have 2 slides that I want to show why this is so difficult to try and prevent or delay type 1 diabetes. So when you give a immune therapeutic, often the effects are transient once you stop giving that drug. So we really need to think about repeating treatments or giving drugs chronically like they do in other diseases like immune arthritis type conditions. Also, it's very slow to develop new drugs all the way through. And it's just hard to get them through this regulatory process. So repurposing drugs that we already use for other conditions can help save time. And we really have to work with drug manufacturers to help with these very costly and expensive trials. So speaking of that, it takes more than 10 years often to do a prevention trial. That takes a lot of money and resources. And there's a limited pool of participants based on how you screen in your country for people at risk for type 1 diabetes, screening for genetic risk or screening for autoantibodies and the cost associated with that. So we definitely need to keep thinking about how we design trials and what our comparator arms are to try and not have large groups of people that have to get a placebo for many, many years. And then if we can develop outcomes that are maybe a little bit closer, so instead of waiting for type 1 diabetes to develop, is there a sooner outcome that we can use that could help save time and money? And then quickly, I just wanted to go through what I think are one of the major difficulties with any of our intervention or prevention clinical trials. So if you have a drug that you're giving and you have a study where, one arm here, the participants that are red and green, they get the drug, whereas participants here in blue get the placebo, what could be other outside things that we're not considering that affect their response to that therapy? So this is actually results from a new onset study where you can see people who got the drug are both in red and in green. So there were people who got the same therapy, the active drug, and some responded to that therapy, and some got the active drug and did not respond. So there are people who will not have the same immune response and beta cell preservation effect that others do, and it may look like the placebo. So we still need to figure out how to identify these people ahead of time. All right, so coming towards the end, this has been our biggest news for the prevention of type 1 diabetes. So this trial using teplizumab, which again is an anti-CD3 monoclonal antibody. You can see here the Kaplan-Meier on the left with the proportion of people who were type 1 diabetes free, so who did not have disease, goes down over time. And those who were treated with teplizumab in the pink line had a significant delay in onset of type 1 diabetes. Again, these are people who have multiple autoantibodies and who have dysglycemia. So they're very close to getting diabetes. It's a very high risk group. But what we found with prolonged monitoring of these people is that they had a median of 3 years delay in developing type 1 diabetes compared to people in the placebo group who had a similar risk of progressing. So this has been very exciting. And what's made it even more exciting is that our regulatory body, the FDA, has approved it as the first drug to delay type 1 diabetes. So we are able to start giving it clinically. Now, it is a new therapeutic, not used in other conditions. So cost and getting it to patients is what we're all working on right now, because it was just approved in the late fall of last year. But I think this really helps break the glass ceiling, which is what I have in the background of this picture, to help get this therapeutic to patients, but also to get more drugs through the regulatory process now that we have one that's approved for use. So what are our next steps, or where can we go from here to try and overcome these challenges and keep improving this field? Oops. Huh. Okay. Sorry about that. Looks like my PowerPoint closed, but I will keep talking. So I have it here. So just as my last slide here, and if I can pull it up, I will, is we have lots of things we can do as a community to help improve. Let's go through this quick. To help improve this process. So what we can do, there we go. Is continue to work on parsing out why some people respond and some don't. Sorry, my PowerPoint's not working. We can try and develop biomarkers to identify who is going to be a likely responder, and again, try and change our trial design so they don't take as long. We really want to direct this treatment to the people who are most likely to respond, and to also make this feasible, we need to have the best predictive tools for identifying people at risk. So population screening is an area a lot of groups in the country are working on. And then trying to get combination therapies, which again, like Lori was talking about, even in the prevention space, combination therapies are more likely to be effective. And as we get more drugs through the regulatory process and partner with pharma, we can get a lot more access to patients. But that's not the only thing that we're trying to do. Okay. We also want to partner with advocacy groups and patients and families with type 1 diabetes. And I think that's something we as providers sometimes forget. So if we're not partnering with patients about what their needs are and what therapeutics they would be willing to take, then we're going to miss the boat here. So I think that's the most important thing. And I'm going to close this because my PowerPoint has stopped working. And I do want to thank everyone at the University of Florida who's helped me with all of my research and who's continuing to work so hard for patients. And I'm happy to take any questions.
Thank you, Dr. Laura, for a wonderful talk. Can you tell us a little bit more on the indications for usage of this new molecule now? Is it for people with just genetic risk or people with positive antibodies? And what has been, the general acceptance amongst pediatric endocrinologists or other endocrinologists in the US? Because we don't have that here, and we would like to know more.
Yeah, and that's a great question. Hopefully it being approved here will help in other regulatory agencies in other countries. So right now, teplizumab is approved for use in people who are relatives with type 1 diabetes who have 2 or more autoantibodies and dysglycemia. So it's very vague, though, what dysglycemia could mean, but abnormal glucose that is not yet clinically diagnosed as type 1 diabetes. is the current indication for teplizumab. And then right now we've mostly done it in the research space. So right now is the kind of the advocacy campaign to get it more out to general endocrinologists and help with the actual logistics of giving the drug, because it's actually a 12-day infusion. So it's about 30 to 60 minutes a day, but that's an IV or a PIC line that has to be used. So yep, it's more to come this year.
A couple of doctors in the audience want to know the cost of the medication if a patient needs to take it.
That is a great question. So we actually have a paper out comparing costs of different therapeutics like this in the new onset space. But teplizumab as a new drug doesn't have a great set cost yet, but it's been estimated to be up to 100,000 or more. So right now patients couldn't afford that. So we are seeing what our insurance payers will cover. So we have 2 patients right now who we're trying to get it in our hospital. And so far, one insurer has covered it to where the copay will just be probably a couple $1,000s for hospital costs. So but that's a big problem and why other drugs need to be pushed forward so that we can have options for patients if the cost is prohibitive.
Since we see a delay in development of type 1, it's not truly prevention, we're delaying the prevention. Would there at some point be a point of time where we give a second dose or a third dose to keep extending that timeline?
Yes, so that is our hope, but that has not been studied in the prevention space yet. So I think now that this drug is approved, we'll be able to do a lot of like post-marketing studies and things to determine how often you need to redose, what's the time frame you can go, what markers do you need to look at. In the new onset period where we're trying to just preserve beta cell function, they've done 2 doses 6 months apart. And it did help to have a repeat dose. So I think that will be something we need to look at more.
Thank you. I see Dr. Rohit raising his hand again. I also see Dr. Samuel Klein and Dr. Buse. So welcome all of you, and please do unmute if you have any questions. We'll let you in. Dr. Rohit.
Yeah, Dr. Jacobson, that is a great talk. I just wanted to get your opinion about the current thinking, whether adding on something that can preserve the beta cell simultaneously with teplizumab might be useful, because as you rightly mentioned, the last
Dr.
30
Rohit,
years has seen numerous clinical trials, and we keep persisting to only focus on the immune component, but completely forgetting about the beta cell. So what is your opinion to have, teplizumab, we still have to wait for another trial to replicate what has been shown, and we keep our fingers crossed it might work. But in parallel, do you think there's any thought about simultaneously preserving the beta cell and on top of that, adding on the immune component? Thanks.
I 100% agree. So the question was about using combination therapy that actually addresses the beta cell that's failing. So we shouldn't forget about the beta cell, and I didn't have time to go into it here, but there are several therapies in the new onset space that have been tested, like rapamil and GLP-1s, to try and preserve beta cell function. And I think that is vital that we use at the same time as an immune therapy like teplizumab. Studies haven't been done yet, but especially for low risk therapeutics, that absolutely needs to be in combination. And I think will be coming in the future years as we learn more about those beta cell protective therapies.
Great, thank you. Dr. Laurie, I see you've raised your hand. Please tell us your question.
Laura, terrific talk. You mentioned about the need for endotypes to really understand who would be responders and non-responders. And I think if the subset of the teplizumab study of those who were zinc transporter positive didn't seem to fare as well as the non-zinc transporter positive antibody group, what are you doing clinically? Are you going to administer teplizumab to those with zinc transporter or not?
It's a good question. So yeah, there was like post hoc or subset studies trying to get more, like Lori and I work on precision directed care. So there is some HLA and antibody specific effects that are potentially seen with teplizumab, but I don't think that study has enough information or is powered to support fully whether someone would respond or not with that. So right now we are not excluding people who have zinc autoantibody because they have another autoantibody as well. But I think more studies and mechanistic studies will help us with that. And maybe we will decide teplizumab is for this group of people, ATG or thymocyte globulin is for this group of people. That is the dream.
Thank you. Great.
Okay, thank you, Dr. Laura, and thank you everyone else for your questions. And let us end this session now. I now request Dr. Saima to come up back on stage to take over. Thank you, everyone.
Okay. I would now like to welcome Dr. Professor A.K. Das, Professor Emeritus Medicine and Endocrinology, Mahatma Gandhi Medical College and Research Institute. Shri Balaji Vidyapeeth, Pondicherry, and Dr. Usha Ayyagiri ma'am, Senior Consultant Endocrinologist and Diabetologist at Apollo Sugar Clinics, Chennai. Over to you, ma'am.
Dear friends, we are in for a great session and to discuss two very important clinical topics of most very important contemporary challenge in the practice of diabetes globally and also our country. Dear friends, we have for the session, we have Dr. Robert Klein and we have Dr. John Bush. The first talk will be by Dr. Robert Klein. So Dr. Samuel Klein, who is going to speak to us on a very important topic entitled "The Weight Loss and Exercise Are the Primary Therapies for Type 2 Diabetes." I'll repeat again, weight loss and exercise are the primary therapies for Type 2 diabetes mellitus. Very exciting topic, a great concept. And to introduce Dr. Samuel Klein. Dr. Samuel Klein is the William H. Danforth Professor of Medicine, Director of the Center for Human Nutrition, Director of the Center for Applied Research, Chief of the Division of Geriatrics and Nutritional Science, and Director of the Weight Management Program at the Washington University School of Medicine in St. Louis, Missouri. He has received numerous awards for his research in nutrition and obesity. Dr. Klein's research activities are focused on understanding the mechanisms responsible for the metabolic dysfunction associated with obesity, particularly the non-alcoholic fatty liver disease, the NAFLD, and the therapeutic effects of weight loss. Dear friends, I have great pleasure in presenting Dr. Samuel Klein to all of you for this great talk. Dr. Samuel, all is yours.
Thank you very much. Can you hear me okay? Okay. It's a pleasure to be here very early in the morning here in St. Louis, and I believe in the afternoon or so in India, but thank you for having me. So I would like to do exactly what the moderator said, and that is to underscore the importance of exercise and weight loss, both as primary therapies for treating patients with type 2 diabetes. Now, we all know that as people become obese, as you gain weight, you develop a constellation of metabolic abnormalities shown here in the middle column of this particular slide. Now, this is true of most people, but particularly true of people from India. So South Asians are particularly predisposed to developing the metabolic complications of weight gain with even small amounts of weight gain. And you can see here that these constellation of abnormalities include insulin resistance and beta cell dysfunction, which cause diabetes, atherogenic dyslipidemia, increased triglyceride in the liver. And also, there's a number of other complications that occur that are associated with these metabolic dysfunctions, which include chronic kidney disease, bone inflammation or osteoarthritis, even dementia and cognitive dysfunction. And these metabolic complications are risk factors, important causes of heart disease and stroke. And so the idea is that if you cause all these abnormalities by gaining weight, the treatment that will improve all of these abnormalities, not just diabetes, beta cell dysfunction, insulin resistance, but improve all of these metabolic complications, is losing weight. And losing weight and increasing physical activity are key treatments to improve metabolic function and health in people with type 2 diabetes and should be the first stage of therapy in people that have type 2 diabetes. As you can see here, you get a increased bang for your buck when you lose weight if you're obese. And so every progressive increase in weight loss from 5%, 10% to 15% causes a progressive improvement in metabolic function, as well as a progressive decline in body fat mass. As you can see here, when you lose weight, and these are patients without type 2 diabetes or obese, you get a progressive decrease in body fat and fat mass. You also get a very marked decrease in intrahepatic triglyceride content. So liver fat is particularly sensitive to a decrease in body weight, and even small amounts of body weight loss, 5%, cause a remarkable 50% decrease in intrahepatic triglyceride content, which progressively decreases with more weight loss. And insulin sensitivity, measured as the glucose disposal rate during insulin infusion. This is a hyperinsulinemic euglycemic clamp procedure where you infuse insulin at a certain rate and then infuse glucose to maintain euglycemia. And so the more insulin sensitive you are, the greater the glucose infusion is required to maintain a normal blood glucose. And you can see here that glucose disposal rate measured as micromoles of glucose per kilogram fat-free mass per minute progressively increases with progressive amounts of weight loss. And this continues to increase until about 15% body weight loss. You can see things begin to slow down, and about 15 or 20% might be the maximum amount of weight loss that you need to get the maximum benefits in terms of insulin sensitivity. Now, this is also shown clinically in terms of clinical metabolic outcomes. And now this is data from the Look Ahead trial, which is a weight loss study in patients who had type 2 diabetes. And you can see if you retrospectively divide the weight loss into buckets of weight loss among these participants, you see that there's a progressive improvement in metabolic outcomes with progressive increases in weight loss. And so losing 5 to 9% of your body weight, you can see causes a considerable decrease in fasting glucose concentrations. Excuse me, causes a decrease in triglyceride concentration, a decrease in both systolic and diastolic blood pressure, and also an increase in HDL cholesterol concentration. But then increasing weight loss more, for example, to 15% weight loss, gives you a greater decline in glucose, greater decline in triglyceride, a greater decrease in systolic and diastolic blood pressure, and a greater increase in HDL cholesterol. So progressively increasing more weight loss causes greater improvements in the constellation of metabolic abnormalities that are associated with type 2 diabetes, as well as glucose itself. Now, this very nice study out of the UK shows that you can achieve these weight losses in primary care practice with an aggressive approach through nurses in primary care practice. This is the famous DIRECT trial that was published several years ago, where they took patients who were in clinical practice who were not being treated with insulin. This was not severe diabetes in primary care practice. And by using a protocol to achieve weight loss in primary care practice, you find that with progressive increases in weight loss, you have a progressive increase in the patients who achieve actual remission of type 2 diabetes, defined as a hemoglobin A1C less than 6.5% for at least 2 months without any diabetes medication. And so if you achieve a 15% here, 15 kilogram, which is roughly 15% weight loss or more, 86% of these patients with less severe type 2 diabetes achieve a complete remission. They don't have diabetes medication and have a marked improvement and decrease in hemoglobin A1C. The less amount of weight loss you achieve, the less remission you achieve as well. And so achieving weight loss, particularly large amounts of weight loss of 15%, are very important in regulating and treating type 2 diabetes. But now the question is, how important is exercise? Because it's much harder to get people to exercise than it is to get people to lose weight, which is difficult enough as it is. And we just completed a study here, this is not published data, of people who are obese that lost weight by either either diet intervention alone or lost weight by diet plus supervised exercise. And we studied them before and after 10% weight loss to understand the additional benefit you would achieve with an exercise program in addition to simply losing weight alone. And you can see here that the diet only group is in the middle. The diet and exercise group is to the right of this slide. The data before and after weight loss by diet only or before and after weight loss by diet plus exercise are shown here, where they were matched on weight loss, total weight loss. So despite the exercise, they were matched to weight loss to match the diet only group. And they each achieved 10% weight loss by design. And you can see this causes a identical reduction in body fat mass from 45.6% to about 41%, roughly in both groups, 47% to 43% diet and exercise group. A little bit of a decrease in fat-free mass as well in both groups. But the group that had diet and exercise had an improvement in muscle strength, represented here, the sum of 1 repetition max testing for both upper and lower body muscles. They also had an improvement in VO2 peak, so cardiorespiratory function also improved in the group that had the exercise training compared to the group that did not have exercise training and simply lost weight by diet alone. They had a similar decrease in fasting glucose concentration, but the diet and exercise group had a remarkable reduction in insulin concentrations, much greater than the diet only group, suggesting already an improvement in metabolic function that's greater in the exercise plus diet group than the diet only group shown here. And then if you measure insulin sensitivity by using this clamp procedure that I showed you before, with whole body insulin sensitivity on the left, liver insulin sensitivity measured here in the middle, and then whole body insulin sensitivity measured by the Matsuda index by using the oral glucose tolerance test on the right. And you can see if you lose 10% weight loss by diet alone, you improve insulin sensitivity in a whole body level by about 35 to 50%, as shown here. You also improve insulin sensitive liver by about 100%, as shown here, and you also improve the Matsuda index again by about 35 to 50%, shown here. But if you lose 10% weight with diet plus exercise, you get a remarkable greater improvement in whole body insulin sensitivity, liver insulin sensitivity, and the Matsuda index oral glucose tolerance assessment of insulin sensitivity. So exercise provides a dramatic addition in insulin sensitivity after weight loss than simply diet alone. Now, this was exercise that was supervised 5 days a week in a worksite intervention. And so this was really rigorous exercise of about an hour every day, 5 days a week, under supervision, which include resistance training as well as aerobic training. And then if you look at the 24-hour plasma glucose insulin profile, and that's measuring blood samples for glucose and insulin all day long in a clinical research unit where the participants had identical meals shown here in gray to match their energy expenditure, and the people who exercise had an exercise bout in the afternoon as shown here by this running man on this figure. You can see that after weight loss in the diet only group in black, shown here compared to white, there's a decrease in 24-hour glucose concentration compared to before weight loss. And there's also a decrease in insulin concentration 24 hours a day compared to before weight loss, shown here in white. The diet and exercise group had a similar decrease in plasma glucose concentration 24 hours a day, but had a much greater reduction in insulin concentration all day long, showing you this additional beneficial effect of exercise on all day long insulin concentration, which we know has distinct metabolic benefits on the metabolic outcomes that are associated with hyperinsulinemia. This slide here shows beta cell function and also insulin clearance rates in the two groups, where after weight loss in the black circles and before weight loss in the open white circles, in the diet only group on the left and the diet plus exercise group on the right. You can see that losing weight by diet alone does not change the insulin secretion rate in relationship to glucose concentrations measured during the first 30 minutes of the oral glucose tolerance test. This is a very robust measure of beta cell function. So insulin secretion rate after 10% weight loss in people who are obese who do not have type 2 diabetes does not improve beta cell function. It also doesn't change insulin clearance rate, which the amount of insulin that's removed from plasma in terms of liters per minute, in relationship to insulin concentration, again, during the first 30 minutes of the oral glucose tolerance test, where you have the greatest increase in plasma glucose and the greatest increase in plasma insulin concentration. In the patients, in the participants that had diet plus exercise, you see the same thing in terms of beta cell function. There's no improvement in beta cell function with weight loss alone, even with exercise in the group that lost 10% of their body weight with exercise and diet therapy. But there is an improvement in insulin clearance. You can see the insulin clearance rate is much greater after weight loss with diet and exercise than after weight loss, than before the intervention. And so insulin concentrations are decreased in patients that have diet and exercise who do not have diabetes because of an increased clearance of insulin, not because of a decreased production of insulin, as shown here with insulin secretion rate. This is a distinctly different metabolic effect of exercise compared to diet only in terms of weight loss, where it improves insulin clearance, but does not really change insulin secretion rate. So we took this information and now we applied it to patients who had type 2 diabetes by enlisting them in a program that caused aggressive weight loss in a worksite-based intervention with supervised exercise training as well. And so in this worksite-based intervention of patients who are obese with type 2 diabetes, where they had dietary-induced weight loss plus supervised exercise training, both resistance and aerobic training, you can see here that the liver insulin sensitivity index shown here on the left, adipose tissue insulin sensitivity index, this is again measured by using isotope tracers of fatty acid during basal conditions in relationship to insulin, and also whole body insulin sensitivity using the clamp procedure, again, looking at glucose rate of disposal divided by insulin concentrations during the clamp. You can see here that the standard care group, there's no difference in liver insulin sensitivity, no difference in adipose tissue insulin sensitivity, and no difference in whole body insulin sensitivity before and after about 6 to 7 months of standard care, usual treatment. But the intensive lifestyle therapy group, the ILT group, who got diet intervention plus exercise therapy, had a remarkable improvement in liver insulin sensitivity, adipose insulin sensitivity, and whole body insulin sensitivity. So providing weight loss and exercise training, which is much more doable in a worksite setting than trying to do it outside of the worksite during a separate session, can provide very potent results in terms of improving metabolic health in people with type 2 diabetes. And if you look at the beta cell function in patients with type 2 diabetes, you see that all day long, in a glucose tolerance test, you see that glucose concentrations after weight loss are much lower than before weight loss in the people that got the intensive lifestyle intervention. Insulin is also much lower with intensive lifestyle intervention when weight loss than before. And here you do see an improvement in beta cell function, where the insulin secretion rate after weight loss, shown here in black, at any given glucose concentration during the glucose tolerance test is higher after weight loss than it was before weight loss. And so patients with type 2 diabetes who lose weight, and this happens if they lose weight by diet alone or lose weight by diet plus exercise, have a remarkable improvement in beta cell function as well as an increase in insulin clearance rates that I showed you previously. Now, the cellular mechanisms that are responsible for this improvement in insulin sensitivity probably occur in muscle tissue. And if you take then biopsies of these participants, this is now the first group who lost 10% of their weight by diet alone or diet plus exercise, and look at the differentiated gene expression, the genes that changed after weight loss than before weight loss, you see that the diet-only group had very little change in muscle gene expression, but the diet plus exercise group had remarkable differences in the genes that were downregulated in blue and the genes upregulated in red, shown here. Dramatic difference between these two groups based on whether they had exercise training or not. And if you look at the pathways of metabolic function shown here, most of these pathways are related to mitochondrial function, TCA cycle activity, beta cell oxidation, mitochondrial respiratory chain, mitochondrial, blah, 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 all the way through, that all the mitochondrial pathways and substrate metabolism in muscle are changed with exercise, but they're not changed without exercise. And these individual gene expressions, some of them I've chosen here that are involved with mitochondrial production, mitochondrial function, such as particularly PPAR-GC1A that's involved in producing more mitochondria, citrate synthase, which is a mitochondria enzyme shown here. These are all markedly increased with diet plus exercise shown here on the right compared to diet only shown here on the left, despite having 10% weight loss. And then if you take the groups that had type 2 diabetes and compare standard care to intensive lifestyle therapy, you see the same pattern where the intensive lifestyle therapy that includes exercise and diet have a marked upregulation and downregulation of multiple genes. These also involve these mitochondrial energy pathways shown here on the right. And if you pick certain genes, expression of certain genes, you've shown here that I've done here in the bottom left, you see that NAMPT, which is involved in NAD biosynthesis, and you can see NAD concentration content goes up as well after diet and exercise, as well as the TCA cycle enzymes in the mitochondria, and SIRT3 and PPAR-GC1, which is involved in mitochondrial biosynthesis and function shown here, are also upregulated in the group that had intensive lifestyle therapy compared to standard care. And you can draw this hypothetical pathway that diet and exercise in type 2 diabetes increases NAMPT, which increases NAD concentrations, and NAD stimulates SIRT-T3 and PPAR-GC1 alpha. This then improves mitochondrial function, which results in improvement in insulin sensitivity. And so here you see a cascade of both a clinical intervention causing an improvement in clinical outcomes in multi-organ system metabolic function, as well as the cellular changes that are presumably involved in producing those organ system changes as well. Now, how do you get people to lose weight? That's really the difficult part, and it is very difficult. We don't pay enough attention to lifestyle behavior therapy, particularly providing this therapy in an easy way for patients who have type 2 diabetes, which would take place potentially at the workplace where they go to work every day, and you can tag on an hour or a half hour every day of an intervention that might improve their health. And so lifestyle therapy alone can maybe get you about 5% weight loss if you do it well. If you do it very intensively, it can get you about 10% weight loss in general. And if it's with exercise, that will improve metabolic health. In the group from the UK where they really had an aggressive program through a primary care practice, this got up to about 15% weight loss in a large percentage of patients. Digital therapeutics, which is using modern day apps and using technology to help people stick to a lifestyle therapy program, can also give you a similar weight loss to face-to-face lifestyle therapy alone without ever seeing a physician or seeing a caregiver. Now we have newer drugs that are GLP-1 agonists and GLP-1 polyagonists like tirzepatide, which is a GLP-1 and GIP agonist, can give you remarkable weight loss of about 20% of weight loss at the end of about a year, which is really a game changer in terms of weight loss therapy with pharmacotherapy. And then we know that bariatric surgery, particularly Roux-en-Y gastric bypass surgery, can get you about a 30% weight loss in general of people who have type 2 diabetes. So these are the tools that you have available to try to get people to lose weight. All of these tools cost money. Lifestyle therapy is not cheap either. You have to really see people on a regular basis and have skilled caretakers to do it. Drug therapy, bariatric surgery is not cheap as well. And so all of these tools cost money, but they are cost effective in terms of getting increased quality of life years. And so in summary, if you can get people to lose weight by decreasing food intake and increase their physical activity with exercise, you will achieve multi-organ insulin sensitivity, increase in beta cell function if they have type 2 diabetes. You didn't show these data, but you'll decrease triglyceride inflammation and fibrosis in the liver. You'll improve cardiorespiratory fitness, muscle strength and function shown here. And also there'll be adipose tissue remodeling and a decrease in adipose tissue mass. Thank you very much. And I'm ready if there's any questions, happy to take them.
Professor Samuel, it was a fabulous talk and it was complete, and I have no audacity of summarizing it. Suffices to mention, you have driven home the point of weight loss and exercise to be part of type 2 diabetes management and its immense benefit, from the clinical benefit to genetic benefit. Absolutely. I have only two questions to ask. Number one is that, do you believe that more and more the type 2 diabetes management must be adipocentric than only being vasculocentric or glucocentric?
Absolutely. We know that alterations in adipose tissue function, particularly fibrosis in adipose tissue, is associated with metabolic dysfunction. We don't know the mechanism for that. We don't know what's being released from adipose tissue that's causing metabolic dysfunction and why it improves with adipose tissue remodeling. But we know from rodent models, it's very, very true that you can show a cause and effect. If you change adipose tissue remodeling, reduce the fibrosis in adipose tissue, and presumably maybe some of the inflammatory processes in adipose tissue, which include exosomes being released from adipose tissue, you can improve multi-organ system metabolic health. And so adipose tissue is the new target for treating type 2 diabetes, although it's been used before. The glitazones all affect adipose tissue, improve metabolic function.
What's your opinion, Professor Samuel, regarding the calorie restriction mimetics for the diet restriction? We have few therapies which are calorie restriction mimetics. I mean, those who cannot do absolutely weight loss through diet, can it be a supplementary element to help them?
Yes, so having a calorie restriction mimetic, which I'm guessing you mean it's a low carbohydrate, higher fat diet. Is that what you're talking about? And so it's some call it a fasting mimicking diet, or making someone look like they're starving by reducing carbohydrate intake, because carbohydrate intake is the key mechanism for stimulating the metabolic response to starvation. We don't know if those have any beneficial effect on metabolic function in people with type 2 diabetes, except we do know by reducing carbohydrate intake, you do reduce the need for insulin and glucose control because you're not consuming carbohydrates. That clearly is the case. But there's no good randomized controlled trials of using a ketogenic diet, which are what you're talking about, in either people with type 1 diabetes or really with people with type 2 diabetes that are well-controlled studies. And that's what needs to be done, because there is some increased risk potentially as well by stimulating ketogenesis and potentially generating hypoglycemia in people with type 2 diabetes.
Thank you. You have a question?
Thank you very much, Dr. Klein. I mean, amazing talk. Why do you think over and above, see, as it is, it's really difficult for us to convince our patients to exercise. And especially when we tell them that the only visible result they see is weight loss, and there's no significant difference between exercise diet alone versus diet plus exercise, they can't see the VO2 max or the future cardiovascular benefits or the metabolic and inflammatory benefits that we talk about. So one, why do you think there is no difference in weight loss between the two approaches? But more importantly, given that there's no difference in weight loss, how do I convince my patients to actually, that there is a benefit to the exercise?
Yeah, that's a very good question. So one, the studies have shown that the study I showed you, we purposely had no difference in weight loss. That was done on purpose. But in the literature, it also shows that exercise provides very little increased weight loss. So if you want to lose weight, it's by decreasing calorie intake, not by increasing physical activity for most people. How to get people to be compliant with an exercise program is very difficult, but it's also very difficult to be compliant with a diet program. And education doesn't work. So you can't just tell people what to do and tell them this is good for your health. you have to really go deeper and understand the barriers for them to comply with an exercise program and a diet program, because everybody knows diet and exercise is good for you. Your patients know that. We even know that eating 5 fruits a day are good for us, but we don't do it. And so the question is, how do you get them to do it? So you really have to have behavioral therapy intervention of skilled practitioners, which we don't pay enough attention to understand the barriers for implementing those lifestyle changes and trying to overcome the barriers. We've done that now by doing a worksite intervention, where every day people come to work. And so 5 days a week, we intervene. It's not just once a week or once every 3 months, where 24/7 they have their usual lifestyle, but really trying to understand what are their barriers when they go home to implementing the program that we're trying to do to help their weight and health.
It will be a toughie to crack. One more question,
Yes.
if you don't mind. The beta cell function, I found it very interesting that in people with type 2 diabetes, you've shown an improvement in beta cell function with the intervention, but not in those with pre-diabetes. Why do you think that is, please?
Yeah, that's a very good question. We don't really know the answer exactly to that. We have some hypotheses, and it could be related to AKT channels and how the density might change in a type 2 diabetic versus a person who has pre-diabetes or doesn't have a diabetes at all. And we know that people that have pre-diabetes or don't have diabetes or obese, they have increased beta cell function potentially, where they have increased insulin secretion rates. And so if you have already increased insulin secretion rates, they don't get better with weight loss or exercise. But in diabetes, you have a defect in insulin secretion rate, and that does improve. So it might be a thing where if it's not broken, it's hard to fix it. But when it is broken, then it's then it is more easy to fix. So even though it's not broken in people with pre-diabetes, it's just not adequate, increased enough to compensate for the insulin resistance. Whereas people who are obese without pre-diabetes, they have high insulin secretion rates that compensates for the insulin resistance.
One final question, if we have time. I've just seen the sub-analysis of the diet fit study today, and I know this is probably a question that might vex you a little, but do you really think, does the type of diet and the type of exercise matter? Because the sub-analysis of the diet fits suggests that certainly for the amount of weight loss, but also the glucose markers, maybe the GL with a low carb diet matters more than perhaps achieving weight loss at any cost with a low fat diet. Would you comment on that, please?
Yes, absolutely. The composition of the diet and the type of exercise definitely matters. First, I'll start with exercise. So endurance exercise is not as good as endurance exercise plus resistance exercise. So resistance exercise has additional benefits besides endurance exercise. Those muscle mitochondrial changes that I showed you don't occur very much with endurance exercise. They occur a lot with resistance exercise. The other thing is that the same amount of weight loss, you have a heterogeneity in the metabolic improvements. So someone who loses 10% weight loss might have dramatic improvement. Someone else may have very little improvement. So there's considerable heterogeneity at any given amount of exercise, but in general, at any given amount of weight loss. In general, the more weight loss you lose, the better off you are. Now, if you lose weight and stick to a low carbohydrate diet, there's no question if you have type 2 diabetes, you reduce your insulin requirements. And reducing insulin requirements is a very good thing because you're giving insulin artificially in people who are getting insulin. You're giving it systemically and not through the portal vein. That causes peripheral hyperinsulinemia. And we know that peripheral hyperinsulinemia causes insulin resistance. So it's a double-edged sword. You need the insulin to maintain a normal blood glucose. At the same time, you're causing more insulin resistance and increasing the risk for cardiovascular disease outcomes. So a low carbohydrate diet is really the goal in patients who have type 2 diabetes. The question is, should you go to a ketogenic diet and really get very low? That has not been carefully enough tested, I think, in terms of efficacy and safety, and those studies really need to be done.
Thank you, Professor Samuel Klein, for this very, very beneficial, very practical guest lecture you gave today. And I hope this will change the scenario of type 2 diabetes management and also increase the weight loss and the exercise in our patients. You'll be astonished to know that from a countrywide study, we found the physical activity, both non-recreational, is hardly 10 to 15%. The physical activity is much less. You saw that paper. So therefore, your talk is very revealing and hope it will be a game changer. Thank you very much. And on behalf of all of us for this wonderful, very practical talk.
Thank you very much. A pleasure to be here. I'm honored to have been invited. Thank you.
Dear friends, we are now passing to another very significant and again very practical talk by somebody whom you know and who has been very close to India, has come many times, and he is no other than John Bush. John Bush was the president of the American Diabetes Association in 2008, and 2019 he received the ADA Association's Outstanding Achievement Award in Clinical Diabetes Research and has more than 400 publications. He is the Distinguished Professor, Director of the NC Translational Clinical Science Program and the Senior Associate Dean for Clinical Research at the University of North Carolina. He has served as a signatory PI. It's a very significant position in the UNC CTSA since 2015 and has been the member of the steering committee since 2019 and a co-chair for the UNC CTSA from 2021. Dear friends, he's going to talk to us on a very, I should say, a very interesting topic. And the topic is, should SGLT2 inhibitors be the initial therapy for diabetes? You know, it's a very, very interesting talk, you know, because we have to see whether this particular drug, which has taken our country by storm, whatever way, being easily available, we call it available, affordable, and also accessible and appropriate. Whether this drug will serve as the initial therapy for diabetes, what is the evidence? Professor John Bush, all is yours.
Thank you very much. Can you hear me?
Yeah, yes, we're able to listen to you.
And can you see my screen?
Yes, we are seeing your screen.
Very good. And do you see this big blue pointer?
Yeah.
All right, very good. So it's really a pleasure to meet with you. It is early in the morning here, so I'll say good morning to you. And I know it's the evening there, so good evening to you. I have to say I'm jealous of the situation in India where cost is no longer a barrier for SGLT2 inhibitor therapy. And I just want to point out as we get started that this creates a tremendous opportunity in India, I think, to make a real difference in outcomes in patients with diabetes and perhaps even in prediabetes, heart failure, and chronic kidney disease. You have to take everything I say with a bit of a grain of salt. We do a lot of work for the pharmaceutical industry, and I've documented some of those relationships here. So the first point that I want to raise is, what do the new ADA-ESD guidelines say about SGLT2 inhibitors? You all know that there's a great deal of glucose that's filtered by the kidney every day. So blood enters the glomerulus, the tissue, the fluid component of blood is filtered through the glomerulus and enters the convoluted tubule. In the proximal convoluted tubule, about 90% of the glucose is filtered back into the plasma space by the SGLT2 transport mechanism, and then later about 10% using SGLT1, and the net of that is no detectable glucose in the urine in the normal situation. Inhibition of SGLT2 results in about 50 to 80 grams of glucose excreted with urine per day. So this is actually a substantial amount of glucose. It is, more or less equivalent to 25 to 30% reduction in net carbohydrate intake a day, which, as we heard from Sam Klein just a moment ago, restriction of carbohydrate to the organism is a major way of improving glycemia. The guidelines point out that SGLT2 inhibitors have intermediate to high efficacy. No inherent associated risk of hypoglycemia is associated with some moderate weight loss. In fact, really more or less equivalent to the sort of less potent GLP-1 and GLP-1 GIP receptor agonists. They have benefits on cardiovascular effects, both MACE events, heart attack, stroke, and cardiovascular death, as well as heart failure and cardiovascular death, as well as renal benefits with regards to progression of diabetic kidney disease, and is an oral once-a-day tablet. In the US and most of the world, it's very high cost, but I understand in India now it's a relatively low cost prescription. I do think it's important to remember that in the setting of kidney disease, because the drug requires glucose filtration by the glomerulus, at lower EGFR, there does seem to be less effect on glycemia and weight, so not as good a glucose lowering drug. That said, if anything, at least as good, maybe even better, for kidney effects and cardiovascular effects. So EGFR does distinguish the glycemic benefits, but does not impact the renal and cardiovascular benefits. So this is the main new figure from the ADA-ESD guideline, and I just mention it and show it to you in case you haven't seen it, to point out that we now think about diabetes as having 4 equally important components of care. And I want to stress that again. To meet the guideline-directed therapy in the setting of type 2 diabetes, there are 4 equally important components of care: medications for glycemic management, weight management, cardiovascular risk factor management, and then cardiorenal protection with regards to the specific choice of glucose lowering medications. And in this figure, you see the boxes on the periphery, and those really are just a sort of reminder and a map to this overall figure of sort of the pathways of care. And at the top, we point out that the sort of basis of therapy in everyone with diabetes should be healthy lifestyle behaviors, diabetes self-management, education and support, and careful attention and best efforts to address social determinants of health, issues like poverty, difficulties with literacy or numeracy, inadequate social support, and those sorts of issues. On the left is marked in the green box at the top that points out that cardiorenal risk reduction in high-risk patients with type 2 diabetes is necessary in addition to comprehensive cardiovascular risk factor management. And the point here is that in the setting of atherosclerotic cardiovascular disease or people at high risk, you would use a GLP-1 receptor agonist or an SGLT2 inhibitor. And if you still need additional glycemic lowering, you would use both. In the setting of heart failure, you would use an SGLT2 inhibitor. In the setting of chronic kidney disease, you would use preferably an SGLT2 inhibitor, though you could use a GLP-1 receptor agonist with proven cardiovascular benefit if the SGLT2 inhibitor was not tolerated or contraindicated. With regards to glycemia management, where this is the other components of care, remember, one goal is achieving and maintenance of glycemia, and the other weight management. But for glycemic management, the new recommendation is that the initial drug therapy could be metformin or any agent or agents that are required, including combination therapy, to provide adequate efficacy to achieve and maintain treatment goals. So the guidance from the ADA and the EASD is no longer metformin for everyone as first-line therapy. Clinical decision-making is important. And with regards to efficacy, the point really is, except for the most potent GLP-1 receptor agonist, as single therapy, the SGLT2 inhibitors are right in there with metformin and most of the GLP-1 receptor agonists with regards to efficacy. With regards to weight loss, Dr. Klein reviewed the general program very, very nicely. But we just point out with regards to achieving and maintaining weight loss goals, SGLT2 inhibitors, again, are as effective as everything except for the most effective GLP-1 receptor agonist. And I would just point out that in some studies, the SGLT2 inhibitors come very close to semaglutide, dulaglutide, and liraglutide with regards to weight loss efficacy. So I point this all out to say that the SGLT2 inhibitors are all over the glycemic management pathways with regards to medication management. So in the cardiovascular outcome trials, most patients were treated with metformin as background therapy when SGLT2 inhibitors were studied. And so that raises the question, how did the guideline writers get comfortable with not requiring metformin as first-line therapy? Well, it really comes from a combination of meta-analyses and subgroup analyses done from these cardiovascular outcome trials. And that's actually one of the new aspects of this most recent 2022 guideline from ADA and EASD is greater attention to subgroup analyses because we now have so many cardiovascular outcome trials. And what we show here is with regards to major adverse cardiovascular events among the SGLT2 inhibitor therapy trials, if patients were on a background of metformin, the point estimate of the hazard ratio is 0.93. But in the setting of no metformin therapy, the point estimate of the hazard ratio is 0.82. Now, there's a lot of interaction between this analysis and the fact that patients that are not on metformin more often will have chronic kidney disease. But the point really is there is no evidence that metformin is required to express the cardiovascular benefits of SGLT2 inhibitors. So that is the reason why we don't require metformin therapy in the guidelines as first-line therapy. I think in the United States, at least, one of the big problems with prescribing SGLT2 inhibitors is that often if you're quite transparent and explicit with regards to the labeling of the drug, there are a lot of concerns among patients with regards to side effects and tolerability. But I think it's really critical for successful prescribing of SGLT2 inhibitors to discuss the advantages, that these are as effective glucose-lowering agents, and I'll show you data in a moment about that, as effective as anything except for insulin and the injected GLP-1 receptor agonist, and they provide weight loss and blood pressure reduction. They have compelling indications with regards to reducing the risk of heart failure, hospitalization, chronic kidney disease, and cardiovascular events. They have certain adverse events that are manageable. Genital yeast infections, which occur in about 5% of women and uncircumcised males. More frequent trips to the bathroom, net about 1 a day, but that may come at an inconvenient time that can be bothersome, and just need to point it out to patients. And then occasional patients have lightheadedness, and I'll go through some of that data later on. There are other important safety issues that are in the label of the drug, but it's important because people will look it up online and that sort of thing, that we are very explicit with them about these issues. So amputations and fractures are really not increased, perhaps only with canagliflozin, maybe ertugliflozin. Euglycemic diabetic ketoacidosis is a concern, but it's quite rare, on the order of 1 to 3 per 1,000 patient years of exposure. And then Fournier's gangrene, the really horrible disease, that may not even be increased at risk. It is in the label of the United States, but certainly is an extremely rare complication and may not be increased by SGLT2 inhibitors. So to improve the tolerability in patients that are on diuretics, you may want to reduce the dose of diuretic, at least temporarily. After the first 3 to 5 days, the diuretic effect of SGLT2 inhibitors isn't particularly marked. And so almost always you'll end up going back up on the diuretic therapy, particularly in the setting of heart failure or chronic kidney disease. Encouraging liberal water intake to minimize the risk of diabetic ketoacidosis. And in the setting of persistent nausea and vomiting, a potential sign of diabetic ketoacidosis, to hold the drug and seek medical attention if it doesn't resolve over hours, or other worrisome symptoms like severe abdominal pain are present. And then the more severe adverse events are rare events. So here's the best data on diabetic ketoacidosis. So the best estimate is potentially doubling or perhaps tripling of risk of diabetic ketoacidosis. But again, the absolute risk increase is on the order of 1.5 per 1,000 patient years. So a very rare event. With regards to lower extremity amputation, again, this seems to have been pretty much exclusively with canagliflozin and perhaps erdagliflozin in the trials. The best estimate from pharmacovigilance data is that maybe a 1.7 hazard ratio, but that absolute risk increase is about 1 per 1,000 patient years, almost exclusively in patients with severe neuropathy, peripheral vascular disease, prior ulceration and amputation, and so it can be mitigated by patient selection. And then Fournier's gangrene, as I mentioned before, I think the best evidence is that it is not a SGLT2 inhibitor associated problem, or not different from DPP4 inhibitors, but if there is a difference, this is a 3 per 100,000 patient year kind of adverse events. How about efficacy? What kind of efficacy assessments were done with the ADA-EASD guidelines? So here is an example of a head-to-head trial of sorts of dapagliflozin versus metformin. This is really a trial in support of using the combination of dapagliflozin and metformin. So the solid line, solid dots are the combination, and the triangles are the metformin, and the squares are the dapagliflozin. And you can see that with regards to hemoglobin A1C change, there's really no difference between dapagliflozin and metformin. With regards to weight, though, you see substantially more weight loss with dapagliflozin than you see with metformin. And obviously, the combination gives you a bit of an additive effect. But the point really is that dapagliflozin and the other SGLT2 inhibitors seem to have equivalent or greater hemoglobin A1C lowering effects than any of the oral agents. And a sort of more sophisticated kind of analysis using meta-analytic effects. If you look at hemoglobin A1C changes in drug-naive patients, so the question at hand, should we be using these drugs as monotherapy? Canagliflozin, dapagliflozin, and empagliflozin compare very nicely to metformin. They're all in the sort of 0.8 to 1% reduction in hemoglobin A1C, and certainly no statistical differences overall between these agents. In general, early in the natural history of diabetes, the SGLT2 inhibitors work really well because the eGFR tends to be very high. And later, when the eGFR falls, they are not quite as effective. And again, these agents come with clear-cut cardiovascular benefits, whereas the other agents don't. The study that we'd really like to have, though, is a outcome study, a large, long study of early stage type 2 diabetes comparing SGLT2 inhibitors and metformin. And I just want to let everybody know that we should have an answer at least by the year 2026, because in Scandinavia, they're doing a study called SMARTEST that will do exactly that, head-to-head comparison of SGLT2 inhibitors versus metformin in a registry-based trial. And then just to remind you, and I'll go through this very quickly because I know you all know this, but it's truly impressive, the benefits from SGLT2 inhibitors. So if you look at overall MACE events, the point estimate of the hazard ratio in the meta-analysis is 0.9, highly statistically significant with no heterogeneity. With regards to overall cardiovascular death, 0.85. With regards to heart failure hospitalization, 0.68, so a 32% reduction in heart failure hospitalizations. With regards to kidney outcomes, so this is essentially a loss of 50% of renal function or renal death or initiation of dialysis, 0.62, 38% reduction in intermediate term risk. If you look in the heart failure outcome trials, in those meta-analyses, whether we're talking about reduced ejection fraction, preserved ejection fraction, it doesn't make any difference. Reductions in risk on the order of 20 to 30%. If you're looking with regards to heart failure hospitalization and cardiovascular death, again, no major distinction about reduced ejection fraction or preserved ejection fraction, but substantial reduction in heart failure hospitalizations on the order of 30%, and reductions in cardiovascular death on the order of 10%. And then finally, with regards to the meta-analysis in these heart failure outcome trials, there's no evidence of heterogeneity based on baseline factors. Importantly, whether or not a patient has diabetes, what their EGFR is, how high or low their NT-proBNP is, et cetera, et cetera, et cetera. So for heart failure outcomes, the data are extremely solid. With regards to SGLT2 inhibitor trials in patients specifically with diabetic kidney disease, so this is both the kidney outcome studies as well as the cardiovascular trials, very clear and consistent response for reduction of events, whether you're talking about MACE events, the kidney composite, heart failure hospitalizations, cardiovascular death, fatal and non-fatal MI, fatal and non-fatal stroke, all-cause mortality. So if patients have diabetic kidney disease, defined as an EGFR less than 60, generally greater than 20 for inclusion in the kidney outcome trials, so EGFR 20 to 60, or a urine albumin to creatinine ratio, we should use these drugs. And when you look at the adverse effects, really only a signal for male genital mycotic infections, female genital mycotic infections, and quote, volume depletion events. And though the point estimate of the relative risk for diabetic ketoacidosis is 3.5, the range extends below 1. But if you were to worry about diabetic ketoacidosis, if you do the math, 56 events in 14,974 people is an estimated event rate of 3 per 1,000 patient years. And again, easily mitigated by instructing patients if they develop nausea, vomiting, abdominal pain to stop the drug and seek medical attention if it doesn't get better over a few hours, or if it's associated with more severe manifestations. So in summary, SGLT2 inhibitors have strong efficacy for glycemia, weight loss, and blood pressure. Only the high potency GLP-1 receptor agonists at high dose are stronger. The various SGLT2 inhibitors have additional indications for prevention of progression of chronic kidney disease, prevention of heart failure hospitalization, reduction of MACE events, heart attack, stroke, cardiovascular death, and in some instances, mortality in general in people who are at high risk, at least. And then the serious adverse events are very uncommon and can be mitigated with appropriate counseling. in the United States, the only hesitation on the part of physicians in prescribing is related to the high cost, which is about $20 a day. My understanding is it's closer to $20 a year in India. So at reasonable cost, there's really nothing to prevent SGLT2 inhibitors as first-line therapy for people with type 2 diabetes or people with chronic kidney disease, eGFR 20 to 60, or a urine albumin to creatinine ratio greater than 30, at least if the eGFR is greater than 20, or in the setting of heart failure, whether with preserved or reduced ejection fraction. So thank you very much. I'd be happy to answer questions if you have any.
Professor John Bush, you have made things absolutely clear, and there is no iota of doubt that it should be the initial therapy for type 2 diabetes. But for the sake of discussion, I like to ask you some provocative questions. The critics, even though the SGLT2 came in 2013 by TGA in Australia, they still say that we want to see long-term effect. I'm just asking for the question's sake. Some critics say that we do not have long-term data for SGLT2, even though we have data for last 9 + 1, 10 years. What's your comment on that?
Well, it's actually a sort of general problem in diabetes data. So we have most of the data that's reflected in the package insert of all the drugs that we have are 6 months to a very few patients at 2 years of very careful follow-up. Now, since about the last 10 or 15 years, we've had these cardiovascular and now heart failure outcome trials and renal trials, but they generally are more like 2 to 4 years, occasionally 5 years of follow-up. So in some ways, the people are making the right point. But I would just point out to them, if they want to be therapeutic nihilists and just say, we know nothing, I'm not going to treat diabetes, we should probably remove their medical license. We have good data
Very
for
well
4
said.
years.
Very well said. The second question is it's again a provocative question. Kindly excuse me. Why European Society of Cardiology was the first to adopt SGLT2 as the first drug, and we came next?
That's actually a great question. I'm not a member, I wasn't part of that writing team. There were a lot of conversations back and forth between the leaders of those efforts, and eventually a paper in Lancet Diabetes and Endocrinology led by Nico Marks that tried to get the two organizations together. There was just total agreement that SGLT2 inhibitors were game changers in the beginning when we just had one trial and then 2 trials. We didn't have enough data to say with certainty that the metformin as background therapy, which is present in 80% of the patients, was an important contributor or not. The ADA and the European Association for Study of Diabetes are pretty conservative organizations. We tend not to make clinical recommendations until we have evidence. The cardiologists are they look at death in the eye every day in their practices. And so in a way, they're more aspirational in their care. And the net of that is, it was a bit of a guess. It was a good guess. Even many people at the ADA had advocated for using SGLT2 inhibitors earlier, but that's, I think, the rationale.
Fantastic answer. The last question I would like to ask you, again, a little provocative. You also said in your brilliant talk that there are also scope of using both SGLT2 plus metformin as the initial therapy. And many believe that metformin is a foundational drug. In whatever trial we did, it was there as a combination therapy, many of the trials. So what's your comment as a clinical practical guidance to my doctors? When will you use alone SGLT2 inhibitor or SGLT2 plus metformin?
Yeah, so the biggest proponent for right from the get-go, the moment someone is diagnosed even with pre-diabetes, Dr. Ralph DeFranzo and Dr. Abdul Ghani have done studies to suggest that the combination of metformin, GLP-1 receptor agonist, and thiazolidinedione should be initiated right at the get-go. They now are thinking metformin, SGLT2 inhibitor, GLP-1, and thiazolidinediones. But for me, my only reluctance is to start with the drug that you think is most important as a single therapy. But the reason is because if there are adverse effects to a combination tablet, you might have lost the opportunity to use both of them because the patient will be reluctant. I don't want to do that. That gave me the terrible belly pain in the beginning. But it was really the metformin that gave you the belly pain and not the SGLT2 inhibitor. So my approach is generally to start with one drug. If a patient has an A1C that's 2 or 3 points away from target, I would start with 2 drugs. But just the patient counseling around that is going to be important in case there are adverse effects.
I'll give it to Dr. Usha for the taking.
Thank you very much, Dr. Buse. I mean, amazing talk. More of a comment than a question, really. Considering our metabolic profile in India, considering our cardiovascular risk, I think we should really be the region that's initiating these trials that run long-term, 10, 15, 20 years for the SGLT2 inhibitors to look at how much they might benefit our subpopulation in risk modulation in the longer term as, if not initial, then as very early co-primary therapy. What would you say?
But absolutely. There is some data that there is heterogeneity by region with regards to outcomes with these trials. But if anything, the benefits seem to be bigger in India, Asia, the rest of the world than in North America and Europe. So absolutely, I endorse everybody doing trials. And the good news is now it would be relatively inexpensive to do a trial like the SMARTEST trial. And I really encourage people to look at that reference. If anybody has difficulty finding it, just let me know. I did share the slides with Dr. Sasali, and so he's welcome to share them with everyone, should you ask him. Arvind, sorry, you're going to get 2,000 emails now. But in any case, it's a great study. It's done in the context of a registry, and so it can be done quite inexpensively.
Dr. Buse, Dr. Arvind here. Thanks for being there for us. And this is the third ADORE that you have been speaking for us. Thank you so very much for that. My question is, you are into precision diabetes, and you had made some clusters. Based on the clusters that you had made, even Dr. Mohan has made his own clusters in India, diagnosis based or classification based on clusters. Do you think there is any cluster wherein an SGLT2 will not fit in?
You always ask tough questions. So the one area that that I'm a little bit concerned about is the use of SGLT2 inhibitors in patients with type 1 diabetes. And so the sort of autoimmunity cluster, the cluster with more insulin, loss of insulin secretion, is an area where, at least theoretically, that TKA risk is higher. Now, that said, I think in the right patient with appropriate counseling, who has access to insulin, you can use SGLT2 inhibitors safely, even in the setting of insulin deficiency. But that's it's really the safety of the drug is more in question in that setting. It's not the efficacy of the drug is in question in that setting.
Dr. Buse, if I'm correct, you have done the trials of SGLT2 in type 1 yourself. What was your experience?
The patients love it. And, it's interesting when we've done many studies of adjunctive therapy in type 1 diabetes. And I would say of all the studies we've done, GLP-1 receptor agonists, SGLT2 inhibitors, metformin, thiazolidinediones, The only time the patients say, I like this drug, is the SGLT2 inhibitors. I think what happens is because they're sort of auto-regulating, that when the glucose is high, they're more effective because we have more glucose filtration through the glomerulus. And when the glucose is lower, they're less effective because we have less glucose filtration through the glomerulus. It reduces some of the variability in glucose, which I think drives some of the sort of not feeling so hot when you have type 1 diabetes. It is associated with nice weight reduction. And the benefit, if anything, I get the sense from patients telling me this, but also from the data, the benefit seems to be more sustained over time than with GLP-1 receptor agonists or metformin or thiazolidinediones as adjunctive therapy in type 1 diabetes.
Okay, one last question before we leave you. We know that you're in your holidays and it's Saturday morning. It's just about 8:30 morning there. And there are no pharma people in this hall. I can assure you that. Now, if you have to choose between the SGLT2s, JAPA versus EMPA versus CANA, what's your choice? No pharma people here.
Yeah. But even if they were there, I would tell you. So because of the little bit of concern about bone fractures and amputations with canagliflozin and erdagliflozin, and frankly, the less impressive data with erdagliflozin in the Virtus trial than the other trials, I would pick dapagliflozin or empagliflozin. And if I had to pick between them, I'd have to say, I don't have great data to distinguish the two. The empagliflozin data is a little bit stronger on mortality. The dapagliflozin data is a little bit stronger on
heart failure.
On heart failure. And so, for me, it's really a coin toss between the two. I know that there are people who are really huge EMPA fans and people that are huge DAPA fans. I'm agnostic in that regard.
Yeah, in India, we are Usha fans. So, this is, her name is Usha. So, and it's a very popular fan, which is called the Usha fan. Thank you so very much, John. Thank you so very much. And then we'll leave you. And Dr. Das has a question.
Not question, I just want to tell you that we have the last Research Society of Diabetes of India meeting have deliberated on a consensus paper regarding making in the last Research Society of India Diabetes meeting, we have wrote a consensus paper which is being written now regarding using this SGLT2 inhibitor as the initial therapy, considering. And while it was being discussed, there was a good story which was told about two American presidents. John, I'm telling in a joke. One American president had tuberculosis and died of tuberculosis because that time anti-TB drugs were not available. But there was another American president who died of hypertension. There was debate going on between Pickering and Platt, remember, whether to treat hypertension or not. So we strongly believe not giving SGLT2 inhibitor is no more acceptable. Thank you very much for a very fabulous talk. And John, we are all your fan, and your talk has made a change.
Well, thank you very much. It's always a pleasure to visit in India. I went there for my honeymoon in 1986, and I was just there getting one of my nephews married to someone from India this summer. So it's great to visit with you. Have a wonderful evening.
Thank you. Thank you so very much.
Thank you, chairpersons and eminent speakers, on a wonderful, amazing session today. Now we move on to the next session on role of SMBG and IPDM in type 2 diabetes by Dr. Bhavna. To chair the session, I would like to welcome Dr. Sanjay Reddy, sir, consultant diabetologist and medical director, CDEC, and consultant diabetologist at Fortis Hospital. Over to you, sir.
Bhavna, nobody needs no introduction. I request everybody who's sitting in the back to come forward. I think it's better you all occupy the chairs front. They look very empty. And all of you are in hibernation. It's good to sleep at the back. Over to you, Bhavna.
Thank you all, and good evening, and thank you for joining us today for day one of ADORE. So today I'm going to be talking on something which is not drug related, but still a very essential part of our management for type 2 diabetes, which is monitoring, looking at values and figuring out what to do with them. Because if we don't do that, which is really the foundation, we don't know if our treatment is working, and sometimes we also don't know what treatment to give. So let's look at the role of monitoring in terms of blood glucose monitoring, not evaluation and testing, and then what we can do to use that in clinical practice. Now, SMBG is a cornerstone of diabetes management. All our patients need to do it. Where is the evidence? Type 1, definitely a must. Anyone pregnant, definitely a must. Type 2 with insulin, definitely a must. They needed to adjust their insulin doses. Type 2 on OADs, well, it's a little bit of a question mark there on does it really benefit, but it can really be important for patients to monitor, even though we don't have very robust clinical trial data. It can be important for patients to monitor because they use that information either to modify what they eat or what they or their exercise, or they come back to us with those values and we figure out what medications need to change. So if we don't have SMBG values, it's not really easy for us to take a call on what is happening to that patient in your 15-minute consultation by just looking at an A1C or just looking at a fasting blood sugar. So we need to know what the patient's values are. And we have SMBG and we have CGM, and both are important and both have their role. CGM is more expensive, so certainly not everyone can afford it. But SMBG can get you closely there if a patient is regularly monitoring their blood glucose at home. Now, one of the gaps we see in practice is patients, one, often don't know which glucometer to buy. That's the first thing. So they buy a lot of meters which are available, which may not even give them accurate results. So you need to tell them which monitors to buy. The second, you need to be able to tell them when they need to check their blood sugar. So if they're checking at a random time that gives you no relevant clinical information, you don't know what therapeutic decision you're going to make. So give them specific time points in a day, how many days in a week they need to monitor. And of course, if they feel highs or lows, they check at that point of time. And today, because we have connected glucometers available, anyone who's buying a glucometer today, please ask them to buy a connected glucometer. The cost is really not different compared to one which is not connected. The reason we know the values are actually the values that they are seeing on their machine. We often see adults and children, irrespective type of diabetes, when they come to you with a book of values, you don't really know if those values are sometimes fact or fiction. And diabetes needs comprehensive care. So if you're going to sit with their logbooks in your 15-minute consult, it sometimes really becomes impossible. So you want to make sure you have enough clinical information from time to time. Even if you are not the one who's looking at this, there could be someone assisting you. The education and training needs to be ongoing. You need to assess the care that is provided and make sure the patient has actually understood what you taught them and not assume that they know what you're saying. Then we need to be able to effectively analyze all of this data that they give us and spend time with them. For patients themselves, sometimes it's hard for them to look at the SMBG data and take decisions, especially if the education is not so good and if they're on insulin, let's say 4 times a day. But for basal insulin twice a day, most people are actually able to adequately learn insulin dose adjustment. So up on the slide are all the gaps that we see, and we need to address each of these things in our clinical practice. Now, some of these factors are patient-centric and the others are just in the system. They have so many things to do, so many medicines to take, and then they just forget that monitoring is an essential part of their day-to-day life. Education awareness is important, but even with that, the other important gap that we face is the doctor-patient communication, where we are not adequately telling them when to check their sugars and when to monitor, what to monitor, and when they should actually come back to you with red flags or signals, because there are going to be 1,000 values and no doctor will have the time or patience to look at everything. And of course, you need to have a good relationship with your patient. Now, if you don't have a team that is helping you do this, it is impossible to get it done for every single patient, because you're not going to be able to spend, sometimes it even takes half an hour to 45 minutes, teaching them how to adjust their insulin doses, teaching them how to use a glucometer or when to use it. So what you need is a team, and what you also need is a more integrated approach. So we all know the importance of SMBG, but we also need to have an integrated system which can be personalized and which can support us digitally. That is what IPDM stands for. And what does that mean essentially? It's a fancy term, but essentially it means that the patient is using a connected glucometer, and you as a physician, as the patient's doctor, is able to also track the patient's records and values over time, because many of these apps have a doctor-facing app where you can actually log in and look at what is happening to the patient. Now, this is not possible to do for every patient, but you could do it for patients who are critical, who really need your support. So pregnant women, type 1, someone otherwise who's very sick, it makes a huge difference. Now, even otherwise, there could be patients who are using the app, downloading the data, generating the report, sending it to you, and you could get graphs and ups and downs and average values for every few days or a week. And you use this information to actually modify the patient's treatment. Why? Because every patient is different, and it is not that every patient requires the same kind of dietary modification or exercise or insulin regimen. We all say that basal insulin is the first insulin to go to when you initiate, but someone else might actually need something different. And there are several case scenarios where you might need to start something that is away from what a guideline generally tells you to do. And that is where doing SMBG, having an integrated system, viewing these values even digitally, can make a huge difference. So what is the basic goal? You sit with the patient, you figure out what their problem areas are, what they're taking, what you need to change, give them an education, and create the awareness that you're supposed to. Give them the therapy, the prescription, and then also the prescription for SMBG, how often they need to do it, when they need to do it, what values are, red flags where they need to actually maybe get in touch with someone from the hospital. But if you have one of these connected meters and you're accessing the information, there could be someone in the hospital filtering this data as well to you. And this data is available on the system, someone analyzes it, and then they get back in touch with the patient for a repeat visit to assess if these problems can be sorted out, whether it's through lifestyle or whether it's through management and changes of their medication. That depends on the case. Now, this particular study is called the PDM Pro Value Study, and they were looking at one simple thing in the study. They were looking at patients in two arms. One arm got usual care, the other arm went through this integrated digital support system, where they were trying to see if having a hospital or a clinic or a doctor managing the patient's values SMBG over time, would it really make a difference in terms of A1C outcomes at the end of 1 year. Now, what was the result of this? That yes, there was an improvement in terms of patients adhering to medication, getting to better goals. In terms of even insulin injections, there was more adherence in patients who were on this program, because their SMBG was being monitored. They knew someone at the back end was seeing it. So there was better adherence, better A1C, also the nutritional counseling also was improved, and the lifestyle changes also were more effective in patients who were on this clinical program. What actually happened to the glucose values in terms of A1C was that at any point of time, month 3, 6, 9, 12, patients who had this additional support program, they had a better A1C reduction of more than 0.5%. So we see the result as early as 3 months, and it is sustained all through. Now, what happens if you take them off the program? well, no one knows, because if no one's watching you, they might get back to their old ways again. But yes, we cannot provide continuous support for everyone throughout their lives, but an initiation even for a couple of months might be motivating enough for patients to follow later on. That would be something interesting to look at, to see how long they need you to watch them, and then how they can manage and maintain on their own. So what is it that we're trying to do? We're trying to initiate adequate treatment at the right time, and we're trying to modify therapy, whether it's diet, exercise, or medication, until you reach that individual patient's goal. And for the patient, how does it help them? It makes them feel supported. It makes them feel that someone is really there hand-holding them. It improves the relationship with the doctor. Now, this is a sort of report that can be generated. Now, for example, this is the AccuCheck glucometer. And if you download the My Sugar app, you could get a report like this if someone uses the meter often enough to log in their blood sugar value. So it gives reds, yellows, greens. You could set your own target range. Now, a pregnant woman would have their, upper limit post meal as 130 or 140. It wouldn't be 180. So you set your own lows, highs, and it gives a absolutely individualized report, which could be sent to a doctor every week or every few days. So we need to ensure that our patients get to goals without having hypoglycemia as far as possible. But that does happen. So we need to educate them about hypo and how to avoid it and manage hypo. We need to make therapeutic adjustments whenever required. We need to ensure that patients adhere to therapy better. Therapy in terms of both pills, injections, diet, exercise, all of that is therapy. And finally, our patients need to be happy. So I think with this, this is my last slide. So I will stop here. But what we're trying to essentially say at the end of this talk is you will hear a lot of things about medications, exercise, lifestyle throughout these 2 days and across different conferences and forums. But don't forget, a key role in all of this is monitoring. And if the patient does not monitor, and if you do not know what is happening, it is not possible for your patients to get to target. So please make sure that monitoring of SMBG and CGM, wherever appropriate, also has its role in your practice. So thank you.
Thank you, Bhavana, for highlighting the importance of monitoring and using technology, the good technology to adjust, probably monitor, and better patient care. Any questions from the audience? I can ask you, but with positive, I am Dr. Bani.
The essential fact that you can only improve what you measure. So we wrote some time back that you can only improve what you measure. In the quality cycle of diabetes care, you can only improve diabetes care if you measure diabetes. And you rightly said, it is quality cycle always say, measure, act, improve. You have to measure it. Therefore, the glucose monitoring is the most fundamental aspect of diabetes management. I think Arvind, remember there used to be time when every diabetes meeting used to have one lecture on monitoring, because it is the essential, the be all end all of diabetes practice. Thank you. Thank you, Bhavana, for a very, very nice lecture.
Thank you, sir.
Thank you, sir. Thank you for the comment. Yeah. Yeah. We Sure. Good evening, everybody. It's my honor to announce the ADORE oration for this year, and I invite our beloved Professor A.K. Das onto the dais, none other than Dr. Eric. Bring round of applause, gentlemen, for Dr. A.K. Das. All of us know he's been teacher of teachers for medicine, and we would dread, so the plaque will be read out by Dr. Arvinder. You want?
It's a pleasure to be here, standing in front of all of you, sharing the same podium where Dr. A.K. Das, very beloved to all of us for the last 32, 35 years, is being chosen as the orator for today. And we are very happy that he's giving the ADORE 2023 oration. To speak a few words about Professor A.K. Das, he's an eminent physician, endocrinologist par excellence. His present designation is Professor Emeritus, Medicine and Endocrinology at Mahatma Gandhi Medical College and Research Institute, Sri Balaji Vidyapeeth, Pondicherry. Just this evening, before we came onto the dais, he gave us the good news that he will be now the director of the same institute. That's something that is not written in the citation because I will blame him because he didn't tell us that. Earlier, of course, as most of us know, he was the professor, head of the Department of Medicine and professor of endocrinology and the director at JIPMER, Pondicherry, the most prestigious college. Professor Das has been a great teacher, great academician, along with being a great administrator. He's been a great friend to most of his students and young doctors who pass out, not just from Pondicherry, but from all over the country. He has represented and chaired many programs of Government of India and continues to do so. He is the patron of RSSDI, past president of API, past president of Diabetic Food Society of India, and DIPSI, which we all know is Diabetes in Pregnancy Study Group. Professor A.K. Das is a very favorite speaker at all the national and international conferences, a very humble, approachable, and always smiling is the nature of Professor A.K. Das, not just with his colleagues, but with the patients. And he's been a great doctor, clinician to his patients. He loves music and art as much as he loves medicine. And this is something that we all can experience when we have dinner, and he is going to give us some of his favorite songs. Professor A.K. Das is the recipient of Dr. Jivraj Mehta Lifetime Achievement Award by the Association of Physicians of India. He has authored many chapters in many books and also has more than 100 research papers to his credit. The Q Trust of Daikon Hospital is honored to present this ADORE 2023 oration to Professor A.K. Das. Now I request Dr. Bhavna Sosle to spread the shawl. May I request Usha Ayagari also to join us on the stage, please? I think both Bhavna and Usha can do the honors. May I request Dr. Sanjay Reddy, that's the backside, Sanjay.
Please give a standing ovation to Dr. Das and a note of applause, please.
Yeah, thank you. My dear Arvind, Sanjay, Bhavna, Madam, all the members of ADORE, I am speechless. I feel so great to be here today to get all your love and all your adoration and praises. I really reciprocate with my sincere love and greetings. Thank you very, very much for this unique honor. Dear friends, I was told by Arvind to speak on something which will be beneficial in our day-to-day clinical practice. So what I have chosen for today's oration, it won't be very long. I assure you that it will be between 25 to 30 minutes max. What I brought for you today is something unique. I have brought for you what are the big data. Big data is the term which is used for big epidemiological studies that has happened recent times in our country. And what are the lessons that you have learned from this big data? Now, these three big data that I'm going to present today, you are aware. One is called ICMR in-depth study, and it has been termed by Indian government as a compendium on type 2 diabetes. Like people say that, a compendium is a compilation of all that happens in a particular area. It's a compendium on type 2 diabetes. The second study that I will give the lesson for the nation is the landmark study, which many of you know. It's a study we started 3 years back. It is our country's first real-world longitudinal perspective study on the complication and the treatment adaptation. It is a study which is ongoing, but I'll present the lessons we have learned so far, which we have published. The third is the Impact India study, which all of you know we started about a year back, and is a pathway for achieving a specific goal which we set. I'll tell you, we did not achieve the goal totally, but we have learned some lessons which I'll put before you. Dear friends, all the three are ongoing projects, and the data I am presenting, about 90% have been published, but about 10% is not yet published. I have got the permission from the PIs to present the data, like from Dr. Mohan for the ICMR in-depth and from the Government of India. And some of the data which are under embargo, I will not be presenting, but I'll allude to it. Dear friend, I must tell you that I had the unique honor of being chair for all the three studies. I'm the co-chair for the ICMR in-depth study from 2008. I am the chairman for the landmark study, and I'm also chair for the Impact India study. So this gives me the unique distinction of knowing what exactly happened and what are the lessons that we have learned from the studies. Dear friends, this is the title we published. Mohan and Anjana were the first authors. That's why we call ICMR in-depth as the compendium of type 2 diabetes, and why is a lesson for the nation. Dear friend, ICMR India study started in 2008. It's a big data survey. It was funded by ICMR, Department of Health Research. is the largest epidemiological study on diabetes in India. The budget so far have been 24 crores. But we have got a lot of data from the study, which I'll present before you. What were the objectives? Dear friend, the primary objective was to determine the national prevalence of diabetes mellitus and pre-diabetes. And we had a lot of data. We have data from body study. We had given to Government of India, we found data is equal. We have to have the data on the pre-diabetes. And also to give the prevalence, not only for one place, for the entire country. That's why the budget went up. India is a big country, so budget went up to about so much money, but it is a state-wise data and union territory-wise data. I'll present before you. Additionally, we wanted to look at two more companions of diabetes. One is hypertension, other is dyslipidemia. I'll put the data before you. And also in every fifth subject, we determine the status of coronary arteries in them, and also looked at the HbA1c in every fourth of them to find out how is the control status. It is a cross-sectional door-to-door survey, and every individual above 20 years who came under the KISS method of statistics to be examined were examined. Dear friends, the sampling framework was 27 states, Delhi, NCT Delhi, and 2 union territories. In each state or UT, we looked at 4,000 subjects. We divided it to rural and urban, depending upon the distribution of the population. We took 2,400 from the 2,800 from the rural area and 1,200 from the urban area. The total sample size that we have screened is 1,20,000. The response rate was absolutely fabulous, 94.2%. We have screened 1,13,000 patients. Dear friends, the study protocol was to take to individuals of 20 years of age. And I've told you at every fifth individual do HbA1c, lipids, creatinine, and in individuals with newly diagnosed cell diabetes, there were a lot of people who knew they're already diabetic. In them, we did the HbA1c to the control status, lipids, creatinine, and we did a 2 questionnaire, the food frequency questionnaire, which I'll give before you. We also did the physical activity questionnaire. Dear friends, we had in this program 113 million variables. So it is a storehouse of excellent data. You can see that there are 130 million variables in the data set, and we want to make it available to everybody to look into it, what they can make out of it. We have published about ISOM Endeavor 1 to 21 papers, mostly in the Lancet, and of course in the IJMR or other journals. I'll put before you. The urban participation was about 33,537, rural about 80,000, male, females, and the age range is shown before you. Dear friends, this is the one which is the latest, which is not yet published, but I have got permission to show it to you. This data of the diabetes mellitus till 2022. It is submitted to the Lancet Diabetes Endocrinology. I just want to tell you that diabetes is a greatly increasing disease, and we had almost 280% rise in diabetes. Look here that we had diabetes in areas of our country, like Kerala was 24.6%. In Pondicherry, from where I come, it was about 25%. But you see, Goa, it was 28.3%. And you know, these colors determine I've given the legend here, and this represents the type of diabetes prevalence we have. It varied from 6% in Manipur to about 28.3% in Maharashtra. And you know, it is soon going to touch 30%. Dear friends, if you look at the age and gender specific weight prevalence of the disease, we found that the disease, as we had thought always, occurred in much younger people. The takeoff was around 30 years of age, to be exact, 29 years of age. And you know, it was a great disease to work with. There was a lot of diabetes in the young, and you know that it was also shown that in the first study that we have already published in 2017, and there we had data from the 15 states, which I'll show you, but subsequently we have data from the entire country now. Now, as you will see here, we found a great relationship between the gross domestic product or the gross domestic product, meaning their prosperity, and the type 2 diabetes. You can see more or less diabetes rose as the prosperity rose. So we cannot deny that there is a relationship between the affluency and type 2 diabetes. And you also found the relationship between the low socioeconomic status and the high socioeconomic status. Now, coming to pre-diabetes, it was very, very revealing. Now, you find here, this is again the data which has not been published, submitted in the same paper to Lancet Diabetes. If you look at the prevalence of pre-diabetes in India, you will find the pre-diabetes is highly prevalent. In a place like Tripura, it was almost 44%. In Kerala, it was 17%. You know, the prevalence of pre-diabetes is very high in our country. So what does it mean? It means that we have not yet won the battle against diabetes. All these pre-diabetics are waiting to become diabetic. Am I clear? They're all going to become diabetic. Now, if you look at the pre-diabetes in the rural area, you will find even in the rural area, the pre-diabetes is widely prevalent. You can find here in Sikkim, the pre-diabetes was 32.8% rural area. In Pondicherry was 23.9, 24%. And you know, the pre-diabetes also is a big problem for our country. Now, if you look at the pre-diabetes ratio, you will find that there are more pre-diabetics than diabetics. Am I clear? It means that the impaired fasting glucose, those who have fasting glucose between 100 and 125, or those who have postprandial glucose above 140 but below 199 are much more than the frank diabetics. And they are all waiting to become diabetic. I was extremely happy when the data was presented that even hydroxychloroquine, they have suggested to be used for pre-diabetes. And Government of India today has approved metformin to be used routinely for the pre-diabetics to prevent at least 40% going into full-blown diabetes. Now, if you look at the prevalence of diabetes in the ICMR diabetes study, we found the urban prevalence was 11.2, rural prevalence was 5.2, overall prevalence was 7.3. However, it occurred at a young age, and you find, if you, the legend is not clear here, if you look at the self-reported diabetes proportional to the newly onset diabetes, the newly onset diabetes were much more than the self-reported diabetes. What does it mean? It means there's a great scope in our country for screening for diabetes. That means we have to organize foolproof screening program to have diabetics young, to catch them young in our society. Now, comparing our study with the data from the PODIS, data from the earlier data from the ICMR, and various other studies, Ramchandra's data of the published in Diabetology, various other data, we found within a span of 25 years, that is 1991 to 2017, when the first data was published, 15 data, the prevalence of diabetes has increased by 180% in the urban area. But what is concerning, it has increased by 260% in the rural area. In certain parts of the country, there is no division. Like in Kerala, there is no urban, no rural area. So, you know, but suffices to mention that the rise in diabetes prevalence is 180 to 260%. And the glycemic control, you will find this line represents the one which is the one which is above 8%, you see that the prevalence of high HbA1c is quite prevalent, and only in 22% cases we had control of diabetes, which is nearer to 7. That means the control in our country is very bad. And the self-monitoring blood glucose, which Bhavna just now presented, you will find that the self-reported cases, the overall SMBG, self-monitoring blood glucose, was done in hardly 12% cases. That means we do not see our blood glucose regularly, our people have type 2 diabetes mellitus. And if you look at the type of management, we found, as expected, it was diet and oral. The insulin was used in very sparingly, and majority of the insulin use again was in those subjects who are mixed therapy. That means insulin plus oral. We call it bedtime insulin. It can be premix also. It can be any insulin also, but insulin plus oral therapy. And you know, but you see, while you found the diabetes prevalence was about 8%, the pre-diabetes prevalence overall was about 10.3%. Therefore, there are a large number of undiagnosed diabetics in India. The prevalence of pre-diabetes in India varies widely in difference, starting from 6% in Mizoram to about 15% in Chandigarh. And today, when you have completed the entire country, the prevalence goes up to 28% in Goa. That means the prevalence is quite high. There is a shift in the epidemic of diabetes from the urban area to rural areas and from older to the younger people. That is concerning, that it is going from the urban to rural area and from the elderly people to the younger people. And we can see a definite epidemiological transition. More developed states, India, having higher prevalence of diabetes, which is we cannot deny. Now, there is one more disturbing fact, and those of you who attended ADA this time have seen this paper, that the highest HbA1c is found in the younger diabetics between 29, you must see in your practice also, between 29 and 40 years, the HbA1c is the highest. So the highest HbA1c level was found in the youngest age group between 20 and 25 years, which is of concern because since they are having high blood glucose for a long time, they will have a lot of complications. In contradistinction, when the age advanced, the HbA1c did not normalize, but the HbA1c was not that high. We had 11%, 12%, 17%, 21% young people. The elderly people also had about 9%, 10, 11%, but it was little less than the young people. There is need, there's the relation to increase the awareness among the patients and the healthcare providers regarding the importance of good glycemic control. You may say why I'm saying this, but it is never enough to speak about this because we start treatment late, we escalate still later. There's a slogan we have given that we start late, escalate still later, and this has to be taken care of and implemented at the earliest. Now, the newly detected cases outnumbered the individuals already known, except in Tamil Nadu, where there's a good public health screening program. Therefore, screening must continue in all the states, and prevalence of prediabetes is much higher, and that has to be taken care of. Now, we also looked at the comprehensive diabetes care, whether we're achieving that or not. Now, I have told you the data on the HbA1c. I'll give you the data on the blood pressure and the lipids. Now, but we wanted to see in our paper number 13, that is the auspicious number for us. We wanted to see we call it auspicious when it gets published. So we found that data that we did a cross-sectional study whether the guideline recommended diabetes treatment, the targets and the health habits in the self-reported diabetes in India is a fact or not. That means we have got guidelines like railway timetables. The trains run late, but we have train timetables. We have guidelines. We wanted to see whether people adhere to guideline or not, at least for the people who are self-reported diabetes. That means we are already diabetic. We cannot see for the people we detected for the first time. Now, it was observed that the comprehensive management through the guideline was not happening in the diabetics who already knew they are diabetic. That means there's no adherence to the guideline. And the A1C data I have already given. If you look at the glycemic control among the subjects who are self-reported diabetics, almost 6,000 people, we found it was good. You can see the H1C, the rural area, urban areas. So it was it was poor in about 29, 28%. So I mean, it is fair in about 35 and good about 34%. So it was not very good. Coming to blood pressure, it was revealing. The blood pressure control amongst the individuals with self-reported diabetes, see the urban and rural, it was the proportion of individuals who had good blood pressure control was about 46 to 50%. That means half of the blood pressure having people were not at all controlled, and diabetes, hypertension stay together. They're the dual epidemic. So the control of blood pressure was also not achieved in 50%. And therefore, this is also a lesson for the nation that the blood pressure has to be controlled. If you look at the obesity component that were discussed some time back when we had Professor Samuel, we found the prevalence of generalized obesity in the ISOMER India population. In the urban area was about 33%, rural area about 17.5%, overall obesity was about 22%. Now, if you look at the age and gender specific of the generalized obesity, we'll find that it was about 40% in about the urban male, in about 30% in the urban female, and it little less in the rural areas. But you come to the abdominal obesity, the treasure in the tummy, the size of the belt increasing, diminishing the length of the life. We found that the urban areas, we had abdominal obesity in 42%, rural area about 25%, overall 30% were abdominally obese. And given here, there are 60% people in Chandigarh. I must tell the state name because we have conveyed this. 64% people in Chandigarh had big tummy. Policemen, lawmakers, law enforcement officers, they all had 60%. So the obesity in the abdomen is a great issue and we have to combat it. Now, look at the hypertension for the analysis we have done here. You see the self-reported hypertension was about 11%. The newly diagnosed hypertension was about 21%, and overall was about 32%. That means in diabetics, the hypertension was quite prevalent, about 32%. Rural is little less at 27, but still high, overall 28%. And you look at the stages of hypertension according to we did only two stages, stage 1 and stage 2. Stage 1 was 140 to 159, diastolic 90 to 99. We found that the stage 1, stage 2 were also quite prevalent. That means all stages of hypertension were high. That means in our known diabetic, the hypertension was at least 40%, and it was in stage 1 and stage 2, and the control was not good enough. And the gender-wise prevalence is given here. It was more as expected in the males in the urban and rural areas. So the key learnings from this was prevalence rates of both abdominal and general obesity are high in India. The lowest rate of obesity was in Jharkhand, but highest in Punjab. I told you highest in Punjab. They also showed that the prevalence of hypertension is high, varying from 20%, 22% in Meghalaya to about 44% in Punjab. The rules of Hobbs for hypertension, I'm not talking rules of Hobbs for diabetes, also valid for the hypertension. We have a huge window of opportunity to prevent hypertension and obesity if you want to take care of lifestyle. Coming to the fat, I'll be very fast. The lipid control among the individuals who knew already they're diabetic, we analyzed them. And to make a long story short, it was quite high, and it was driven by low HDL, because that was one, we took only three, the lipid triad, low HDL, high TG, high LDL. We found the prevalence of population individuals of diabetics who had any degree of hyperlipidemia almost approached 90%. That means it was very high. The profile of dyslipidemia was about 70% to 89% in various populations. If you take any one of them, not taking all the three, not all the three of low HDL, high TG and high LDL, taking any one of them. Now, but you see the amount of lipid medication, the people who are taking anti-lipid drugs, which are available and which are proven today. Statins are proven to prevent heart attack by 30%, 33%. And SGLT2 is also spoken of as the modern statin. Am I correct? To prevent heart attack. So statin number one, SGLT2 comes number two. But they see the use of statins in our country. Hardly 15%. So therefore, this lesson that our doctors do not prescribe statins. I don't know why it is not prescribed. Now, coming to dyslipidemia component again, I have given the detail, I have no details of it. I told you about quite high. Now, look at the risk factors. This I was telling when we discussed about the physical activity. Now, this paper showed the physical activity and inactivity patterns in India. It was one of the earliest papers. Now, you look at the people inactive. If you look at the inactive people, in the rural and the urban areas, it is shown here, 57%, and in the urban areas, about 72%. And in those who are active was between 34 to 25. That means the inactivity was much less, and quite active people were less than 9% or less than 4% in the urban areas. So activity is much less. And those who do at least 150 minutes per week, moderate to vigorous intensity leisure type physical activity was almost less than 15%. That means as a nation, we are sedentary. Now coming to dietary factors, I'll go very fast because it's very complicated. To cut a long story short, the rice and the millets were the staple food. Wheat and millets also taken in northern India. And I know the non-vegetarian, vegetarian food I've given here. But what we wanted to show that if you look at the food, the carbohydrate load was very high. The carb load was very high, and the mean servings of the fruits and vegetables, the WHO's STEP trial was much less. Vegetables servings and the fruit servings are much less, and this shows the various types of food that is consumed in the various states of the country, and their cardiometabolic risk factors given as a published paper. Now it was looked into, can diabetes be reversed? Now this is a study which is done by one of the academicians who works to reverse diabetes, and it has suggested that new onset diabetes and you can prevent, and the permanent diabetes you can give a long way to cure if you reduce carbohydrates. If you can reduce the carbohydrate by at least 8 to 13%, increase protein by another 8%, and also the dietary fiber increase by another 2.5 to 5%. So this is the way we said that one can achieve, along with drugs, remission for diabetes mellitus. Now, I will not go to details of it because we already talked about it. Policy change. Last two talks are very, very small. I'll just allude to the Impact India study. And I'll just show you that this Impact India study, we found that in 2018, on the discovery of insulin 100 years, we wanted to see that can we reduce H1C by 1%. And that was the objective. So from the average H1C was about 8.56, we wanted to reduce into 7.56. We did fail miserably in spite of all our efforts. I'll show you what was our ambition. I have told you, and I'll show you what did happen. Now, this study showed us that if you want to reduce H1C, we have to work with the healthcare professional by medical education, scientific expert meets, workshops, dialogues, a lot of media activity. We have to work in the societal level. We also work with the people with diabetes. Now we had a lot of meetings with healthcare providers, clinics, and the people. you see here that we could bring down the H1C in the beginning from 8.56 to 8.37 in 12 months. It is at the community level. Individual level, we bring it back. At the community level, 8.37. And when we let loose after 1 year, it again went up to 8.59 or 9. That means that reducing H1C is not easy at a community level, general level. For individual patient, you can reduce. For that, you need lot of concentration, lot of effort, and that must be done. That must be done. So I'll show you the lesson that we learned out of it. We found that the doctors have limited consultation time because it was a revelation that doctors did give consultation for 2.5 minutes, many government hospitals. Professor Usha, for whom we have all become fans, she gives 10 to 15 minutes per patient. But there are people in the government clinics, they give 2.5 minutes, just come and go, repeat clinic, diabetes is a repeat clinic, and there's a high carbohydrate diet, high relative contribution of PPG, high proportion of patients with high H1C in spite of multiple OADs. So we need simple regimens if you want to give even newer drugs and the insulin. So we need delivery of the effective care by simple and easy explainable treatment protocols. We must use the nurses and paramedics. You may be saying the way I'm talking public health. It's a must. We must use the nurses and paramedics and the educators, increase the treatment capacity at the primary healthcare centers, and supplement with the technology. We have to modify the diet, adapt therapy to Indian diet and lifestyle, reinforce exercise regimen. You can never forget to carry your legs. So exercise is a must. Selection of medications properly, and adapt therapy and target both fasting and the PPG. You must do proper patient counseling. And when there are 3 OADs not working, 4 OADs will not work. This was shown by the impact study. This is also shown by the next study. You will find if the 3 OADs are not working, adding 4th and 5th doesn't benefit much. It's a time to switch over to, at least a time to switch over to insulin. And we had, if the insulin in our country is a sad story. It's between 19%, 22%, and standalone is single-digit percent. With OAD, it's about 17 to 23%. So therefore, there is a need to give appropriate insulin whenever necessary, not to everybody. At least 20%, 25%, 30% people need insulin. That must be given in type 2 diabetes mellitus. The last few minutes, I'll talk about the landmark. It is a study which was in about 370 sites in our country. Large-scale longitudinal prospective observational study to investigate management and complicate type 2 diabetes. It is an ongoing study, and I'll just show it was 6,236 subjects are recruited in the study. You can see many of you can recognize the people who are members of the committees. And the various timeline of the study I've given here. But what I'm passionate to show that we have last 2 years, we have published the study design and the methodology, which has also opened up newer studies in Colombo and also in the other Southeast Asian countries. So whatever way we designed the study, the rationality and the study design and the methodology we had published in the diabetic medicine, this has been accepted. We have published the baseline characteristics and 1-year trends, which I'll show the lessons we have learned out of that. Now we have data in 4 categories. I'll not bore you with all the data. The glycemic data, the glycemic trend, what therapy trend, complication trend, and what happens in metro and non-metro. Now, these are the various posters we have presented last year in the ADA and all our RSSDI. I will just go to the data that we have we found about total of 57 new microvascular complications the first year. The greatest complication was neuropathy. The next was nephropathy and retinopathy. If you look at the macrovascular complications, it was mostly heart complications. The microvascular complications are more common in patients with H1C more than 7. And CV risk also is higher when the H1C was higher. I've given the type of therapies that people use. OADs maximum OAD plus insulin between 24 to 33%, and OAD plus injectables. Again, other injectable other than insulin like GLP, all that is much less than 1%. But what are the other types of people use almost equally well basal and premix. People also use prandial insulin in about 5 to 7%. GLP-1 analogs were used in about 2%, less than 2% cases. Now, it was observed that the neuropathy remained the most commonly reported complications. Biguanides and issues are still the most commonly prescribed OADs for type 2 diabetes. Basal analogs and premixed are the most commonly used insulins. Now we found at the end of first year, today second year data also available, that the fasting plasma glucose is about 126, PPG about 180, H1C about 7.4. So it has shown that there is an improvement in their blood glucose parameters in the 6,236 patients. And they found that those who receive more than 3 OADs, I referred to that, the A1C fall was less than average. So we found that using more than 3 OADs is not ideal for the A1C. It's better to switch over to insulin. We had total death of 41 in the last 1 year and 8 months. And most of the deaths were because of the cardiovascular agents. We have not identified the amount of heart failure, coronary and non-coronary deaths. We looked at the metro and non-metro experience. The glycemic parameters of FPG, PPG, H1C in metro and non-metro were comparable. But the microvascular complications like retinopathy, nephropathy was higher in the non-metro cities. And trends for the large vessel disease like heart attacks were comparable in either of them. So to conclude that the marked improvement in all the glycemic parameters from baseline, a large majority of the participants remained uncontrolled, but few improved. Improvement was observed in subgroup of participants with vascular complications and severe risk. Therefore, one has to optimize diabetes management. Dear friends, I will stop here. I will not go into the other data which has not been published. So I just wanted to say that the big data that we had done for these 3 studies, most important ICM and INDIAB study, and 2 small studies like IMPACT and Landmark, has given us lessons. And it is up to us to take the lessons and implement in our clinical practice. Thank you very much for a very patient hearing.
Thank you very much, Professor Das. It's customary not to have any questions after an oration, so we will not be having any questions. I request all of you, including Dr. Das, Usha, and all, to join us for dinner. And there's also fellowship, so you can be there. I think it's been a long time since the doctors took care of the pharma group. So I request everybody from the pharma to join us for dinner and drinks, and then we're going to forget that we are doctors and then pharma colleagues. So we're just going to be friends. I think let's have a great time. And then just an announcement. Tomorrow we are starting at 9:30 in the morning, actually, because one talk had to be introduced early by Dr. Arpan. So we are starting at 9:30. And then Sanjay has promised that the coffee tea stall will be operational from 9:30 itself. So let's all assemble at 9:30, and we're going to have a great quiz contest of all the PGs towards the end. And then it's going to be the diabeto physicians and DM postgraduates fighting for that particular test. Please come and join us. And I'm not going to say good night. I think I'll say good night to everybody down there when we meet for dinner. Thank you very much.